हाँ वही तो चक्कर, वही बोलता हूँ अभी। करता हूँ सर, करता हूँ। अच्छा। अच्छा, नाला साफ करवा रहे हैं। सर मैं अपने आप को को होस्ट नहीं बना पा रहा। अच्छा आप, मेरा नाम अरुण कुमार है सर, वो वाला होस्ट। ठीक है, हाँ ठीक है। ठीक है
Good morning. Good morning, everyone. Good morning, respected the seniors and my dear colleagues. Welcome back for the day 2 of our academic feast. I hope everyone had a great time yesterday. So we move ahead with our first session. For the first session, I invite upon chairperson, Dr. A.N. Gangopadhyaya, sir, and Dr. Archana Gupta, madam. Hmm. And I request them to introduce the speaker and invite the speaker. Ma'am, the speaker did not.
This session, good morning, everybody. In this first session of today is the presenter is Professor Party Stephens, and his qualification is PhD in medicine, and he's the National Polish Board in Pediatric Surgery, and is a fellow of European Board in Pediatric Surgery. He is head of Department of Surgery and Urology for Children and Adolescents, and he's affiliated with Medical University of Poland. His achievements are president and subsequent board members of Polish Association of Pediatric Surgeons. His leadership of ministerial team responsible for the planning of major oncology cases reform in Poland and membership of National Cancer Plan team in Poland. His experience in pediatric oncology and pediatric minimally invasive surgery is high, and he has published around 195 scientific articles in various journals. He co-authored he has co-authorship of Polish and foreign textbooks, and he has published number of citation in close to 8,000 and co-authored 30 book chapters. So I would like to invite Professor Stephen for his presentation.
Hello, welcome again. It's the talk which I was supposed to deliver yesterday, but due to these travel problems, I can do it only today. And I wanted to share with you our experience with HIPEC. As we all know, tumor cells can disseminate within peritoneal cavity. This occurs through several mechanisms, and these tumor seedings are difficult to tackle. And actually, the best option is hyperthermic intraperitoneal chemotherapy called HIPEC. But what is essential to do HIPEC and what is an essential step to achieve success in HIPEC is complete cytoreduction. And this is very, very important. And only then real intraperitoneal chemotherapy under hyperthermy follows. And that's not easy to achieve cytoreduction. You often encounter pictures like that, and these tumor seedings, these small nodules, go into hundreds and sometimes even more. And they can involve the whole abdominal cavity, they can involve diaphragm, they can involve the liver, as you can see down there. So, and very often the Douglas cavity is involved and the posterior peritoneum covering the bladder. So these are difficult things. And, you know, not infrequently you see the picture like that after your surgery with so many jars filled with several tumors. And essentially we try to resect all of them. Often you do peritoniectomy. So in these big jars usually have a big pieces of peritoneum with several tumors. Of course, you have to do a mentectomy. You have to remove the falciform ligament of the liver because often the tumors seed there too. And then the next step is through HIPEC. For this you need a special pump, which with a reservoir of intravenous fluid to which cytostatics are added. You need thermoprobes, which measure the temperature, which should be around 41 degrees Celsius. And then fluid is circulated for around 1 hour. And you can do it with open or closed technique. We always use closed technique because it's safer. So we close the abdomen, put the drains, you'll see it, and then circulate the cytostatic and remove the drains towards the end of the procedure and keep 1 or 2 for draining residual fluid for the next few days. So this is how the setting looks like with HIPEC pump. There are, of course, several models which you can use. And what is the history? The history goes back to 30s, where Dr. Meigs from New York the first described cytoreductive surgery, but the HIPEC for the first time was used in late 70s. And the first HIPEC in child was done by Andrea Hayes-Jordan, who is a dear friend of mine. You can see her with me down there. And the first Polish pediatric HIPEC was done about 10 years later in Gdansk. And we are the only pediatric center doing HIPECs in children. And this is how the patient looks like towards the end of procedure. Just before HIPEC, you see you have several drains. You have influx drains, you have outflow drains, and you have also the thermal probe to measure the temperature. The advantage of HIPEC is that these peritoneal seedings are very difficult to tackle because peritoneum is not well vascularized and systemic chemotherapy does not penetrate well into the peritoneum. For that reason, the chemotherapy, which is applied locally on the surface of the peritoneum, can penetrate to the depths of about 1-2 millimeters and can destroy any residual cells. But that's why cytoreduction is so important, because if you have big seedings, big nodules, they will not be killed by intraperitoneal chemotherapy. So that first step is absolutely essential. And that has been proven by many papers, actually. What are indications for HIPEC? There are many. I would say the classical one is DSRCT, desmoplastic small round cell tumor, which has this specific predilection for peritoneal carcinomatosis, but also soft tissue sarcomas, mesothelioma of the peritoneum is another one. Sometimes inflammatory myofibroblastic tumors, which usually are benign, but they also may create intraperitoneal metastasis, germ cell tumors, or typical adult type carcinomas like ovarian, colon, or gastric, and some less frequent tumors. What cytostatics are used? The main one is cisplatin, and for most of our cases, we use cisplatin only. But in some cases, you can add doxorubicin, but you can also use, especially in cancers, oxaliplatin, irinotecan, paclitaxel, or 5-fluorouracil. So the potential advantages of HIPEC is that it allows to achieve high concentrations of cytostatic locally in the peritoneum, and at the same time, exposure to systemic chemotherapy is reduced, but still remains there. And one has to remind that cisplatin is a nephrotoxic drug, so you have to hydrate these children properly before and after the procedure. And there are a few pediatric papers. The biggest series was published about 10 years ago by Andrea Hayes Jordan, which included 50 patients, young adults and children, and the main survival was close to 2 years. And as you see, the main indication was DSRCT, and as I already stated, this is an ideal indication. And there was a significant difference in median survival between HIPEC group and if cytoreduction was achieved. That's why it's so important. You see, in complete cytoreduction group, the difference in survival was about 30 months versus 7 months. So it was, in fact, quadrupled. That's another paper which comes from French group, published also around the same time, 9 patients, and 4 of them, so around 50% are alive in complete remission, and the follow-up was median about 5 years from 2 to 10. Another paper of Andrea Hayes Journal, which focused only on DSRCT, and again, patients who had almost complete reduction, CR0 or CR1, had very significant benefit in terms of survival, which reached up to 5 years. And finally, one more paper from Jörg Fuchs group, which also showed similar results and showed some similar indications. Okay, that one we already discussed. So what is our experience? In the last 8 years, we did 15 HIPECs in 14 patients, because you can do re-HIPEC also in selected cases. So one patient had the procedure twice. We mostly use cisplatin. Our youngest patient was 6 months old infant, and with inflammatory myofibroblastic tumor, which was disseminated in the peritoneum. And for this patient, we did normothermic variant of HIPEC. We didn't want to take a risk of hyperthermia in such a small baby, so we did normothermic modification. And out of our 15 patients, 8 remain alive in remission. Some of them under treatment still, though. So you see, these results are pretty much consistent with other literature data. You can achieve around 50% of long-term survival. I'm afraid to call it cure, but at least you can extensively prolong survival. And if you look into individual cases, as you see, most of them received cisplatin. There were some deaths, mostly from tumor progression, but one patient died in full remission from metabolic reasons with DSRCT. So actually, this was not really disease related. It was a complication of treatment. And we had one postoperative death. Actually, it was a common patient of Jan and us, a very severely pretreated girl who developed lots of toxicities after previous chemotherapies, and she died of toxicity after treatment. So this is what you see before abdominal closure, the drains already in, and we'll be closing the abdomen and then start chemotherapy phase. The biggest problem, which sometimes leads to abandonment of the whole procedure, is when you get infiltrates involving the bowel loop, because then you take the risk of multiple perforations. You can resect a portion of the bowel during HIPEC. You can create stoma or take a risk of anastomosis, having in mind that healing may be jeopardized due to chemotherapy exposure and extensive procedure. But if you find multiple infiltrates between bowels, then sometimes you have to abandon the whole procedure and don't deliver chemotherapy, because that simply doesn't make any sense and will not bring any benefit. And out of this series, we had about 3 patients in whom we are not able to achieve clearance and to do HIPEC procedure as planned. And actually, majority of them were ovarian cancers, carcinomas. I think one was DSRCT, very, very advanced DSRCT. And that's how the abdomen looks like after closure, with 4 drains, 1 inflow drain, 2 outflow drains, and temperature probe. So in conclusion, I can say that HIPEC is technically feasible in pediatric population. Patient selection obviously is important, and we do not select for HIPEC any patients who has distant metastasis, because obviously the benefit will be limited, if any. So we try, apart from regular assessment, standard imaging of the abdominal cavity, to do PET or request PET in all our patients to be 100% sure that there are no actively metabolic metastasis. So many of these patients are treated with systemic chemotherapy initially, and once they achieve clearance of distant mets, if they were present, only then we select them for HIPEC. We try to introduce HIPEC into our protocols a little bit earlier. In the beginning, many of these children were very severely pretreated with several lines of chemotherapy, obviously without much success regarding peritoneal clearance, and that led to complications. So now we try to incorporate HIPEC much sooner and in our protocols. And if the patient does not have any mets, then we prefer to do it about 6 to 8 weeks after original surgery, which was biopsy or resection of primary tumor. And talking about distant mets, liver involvement is not a contraindication to HIPEC, providing you can resect it during the lesions during the original procedure. If it's multiple involvement, and we are not talking about peritoneal surface lesions covering the liver, then I wouldn't select such a patient. So at the moment, we are trying to pass this message to our oncology colleagues to refer the patients sooner than later, in order to avoid the disease being too advanced and patients to be too pre-treated and too many complications of chemotherapy having. And actually, that's one of our patients. He's 3 weeks after HIPEC. I had to promise him that he will be able to travel to Rome, because it was his dream to meet the Pope Francis. So as you see, 3 weeks after HIPEC, he was capable of taking this travel and attending the Pope's papal audience. Thank you so much.
Definitely very inspiring study, doctor. And I would like to know whether we have any Indian study or somebody in India doing this practice. Nobody is doing. You are doing in adult. You are. Okay. So what are why we are not starting? Yeah, is there any issue, or and how was your experience with adult population?
So I'm not a surgeon, but I'm a medical person. But for ovarian cancer, for desmoplastic small round cell tumor and some malignancies of the abdominal cavity, which are having widespread dissemination. HIPEC is being practiced at AIMS. I don't, since I'm not a surgeon, I don't have the data to share with you. It is a costly procedure in terms of the cost of the consumables. So that is one of the things which kind of also limits it, but otherwise it is being done. It is not that it is, and it's not just being done at AIMS, it's being done at other places in India as well, in adults.
So very few isolated cases, and we don't have any statistics related to this.
It may be
procedure.
there, but I'm not aware of. I'm sure there would be some data.
Okay, Dr. Pasan, can
if
you
I
add
can-
something?
Can I comment on that?
Yeah,
Because
sure.
this is exactly how we started. We liaised with our adult colleagues because they really have significant expertise. They do I think in Poland, there are only about 1-2 HIPECs per year in children, and we are the only Polish pediatric center. And this is an example of centralization, which we are talking about. Adults are doing hundreds of HIPECs, so they have significantly bigger experience. And it does not make any sense to buy a machine which is costly and costs about 100,000 euros just for pediatrics. It's better to utilize, like you were saying, adult service and just liaise with them and ask them for help because they have more expertise. They have the machines. The problem are consumables, which are costly, and it's probably like 500 euros per procedure, maybe 600 for the consumables. So all these probes and drains.
Dr. Ankur, please.
So excellent lecture. Just to understand the technical part a little more, you put the drains at the time of original surgery.
Yes.
For the installation of the chemotherapy.
Yeah.
So is it only one course after that, or you can also, if the
No, it's
child
one-
tolerates it?
It's one course.
So can you repeat it if there is no toxicity after, and you keep the drains and do another month to reduce it even further?
No. Then you would take a high chance for infection and other complications, you know. So it's a single.
It's a single course.
Single course of chemotherapy. Then you wait for about 2 or 3 weeks and start standard systemic or continue standard systemic chemotherapy. If you have peritoneal recurrence after HIPEC, after several months, we can redo HIPEC. Initially, we are very afraid, you know, how you will be able to do any dissection in the peritoneal cavity, which was deperitonized in many areas. But you can do it. I mean, we're of course supported by adult colleagues who have more experience, but you can do re-HIPEC in highly selected cases. You don't remove the whole peritoneum. You only remove involved areas, but mostly the area which is most involved is the pelvis. And there you have to do extensive peritoneectomy, and that's quite difficult, removing the peritoneum from the bladder, from ureters, from the rectum, from ducts. And so you have to be really careful in this area. And it's, you know, you just remove the whole flap of the peritoneum with all lesions.
Okay. Yes, Dr.
Yes.
But has there been a situation where you would need to put in the drains later if there is a development of, increase in metastasis or something later we need check while treating the patient? That is one, whether it can be done later. And second is, can we not do this by an interventional radiological procedure?
Okay. You put drains under visual control, and you keep at least 1 or 2 drains after the procedure to control the outflow of residual cytostatic containing fluid from abdominal cavity. So that usually takes 4, 5, 6 days before you can remove all the drains. As long as this charge continues, you keep them in. And of course, when you remove them, you have to remember it's still potentially toxic fluid for the staff containing the residuals of cytostatic. So you remove them with special technique, trying not to spill the fluid around, and, you know, and you put them in a special waste container, etc., etc. Regarding your question, I mean, putting the drains for peritoneal fluid collection due to recurrent disease, I presume that's what you meant when you because when you get fluid collection in the abdomen, let's say months or after hypec, this is probably an indication that you have recurrence, mostly in these children. The problem is that peritoneal lesions are very poorly visualized on any imaging, on PET, on CT, on MRI. So actually, what we rely the most is the initial operative report of the person who did the biopsy or of the person who resected the primary lesion. And if intraperitoneal mets were found originally, we believe they are still there, even though they are not visualized mostly in any of the studies. The only thing eventually you can see is just some thickening of the peritoneum. This is mostly what you can see, especially in the pelvic area. But you really cannot see this lesion. They are tiny. Many of them are 1 millimeter, 2 millimeters. They're very, very tiny lesions in abundance. So if you insert the drain later, it's only for palliation reasons. Because as I said, installation of chemotherapy for multiple regions which were not resected, for which cytoreduction was not achieved, does not bring any benefit. It's really useless, essentially. So if you insert a drain later on, it's just to control the fluid and improve the comfort of the patient, and not really to treat the patient with additional intraperitoneal chemotherapy. If you want to retreat the patient, then you have to do re-hypec again.
Yes.
Yeah, that's a very good question. It's high. Most of the patients get paralytic ileus for a few days. But our experience is that in children, it resolves much quicker than in adults. So most patients are tolerating at least oral fluids within 5-6 days, I would say, around 5 days. In adults, that can be much more prolonged, and it is sometimes problematic. And sometimes you can get standard adhesive ileus. We had one case like that. In this series of 15 hypecs, we had one case of adhesions, early adhesions, and that patient was reoperated and adhesions were taken down, and that all happened within 1 week after the original hypec procedure.
Yes.
So I think in this operation, there are two aspects or two parts to it. One is the cytoreductive surgery, the other is the chemotherapy. So if we have a lot of residual disease, then with no fluid.
Yeah.
Yeah. Right? It's not going to work. My question is going to be, would we have done just cytoreductive surgery without the intraperitoneal chemotherapy in some of these tumors? For example, like inflammatory myelodysplastic tumor. I have had one patient who I just done repeated surgery. After the third surgery, it stopped, and now 15 years later, it never come back. And also nowadays, there are other methods of treatment. So even for the ovarian sarcoma, there are some that they actually have dissemination, but many of these are actually the benign tumors, and I find that just by picking them up is probably sufficient.
Yeah, I think that's an excellent comment. Probably you could, I agree, because an idea to giving chemotherapy is just to get rid of residual cells, malignant cells essentially, or but we presume that if the tumor becomes disseminated, these children had some potential for spread. And that's why we decided to use chemotherapy. But in this setting, which you mentioned, and in these diagnoses, probably you could do cytoreduction only, and there is a high chance, I think, you could achieve a tumor clearance and a good effect. Fully agree. Maybe one more thing. There is another type of procedure which we have never done in children, and in adults, there is only one Polish center which has equipment for that, and that procedure is called PPAC. And PPAC is peritoneal pressurized chemotherapy, which is instilled into the abdominal cavity in a form of aerosol. So it's essentially, it's not fluid, it's aerosol containing cisplatin. But that's used in two settings. First of all, you do it laparoscopically because you need complete seal. So you cannot do it in any open surgery. And either it's a palliative procedure or it's a procedure which is like a bridging procedure to hyper. So if you have the disease which is so extensive that hyper cannot be done, then you could do PPAC. That can be repeated 3 or more times. And once you achieve some clearance and some improvement, you can go for HIPEC and achieve complete cytoreduction and, you know, and then proceed in a standard fashion. But we've never done it in children, so I don't have any experience.
Can this HIPEC therapy can done by laparoscopically also?
No, HIPEC no, because you will never be able to achieve clearance. You have to do it open, and it takes several hours. You see, you've seen in a table the long operative times. This procedure can take sometimes 6 hours, 7 hours, 8 hours. And actually, most of that time is cytoreduction phase. It's chemotherapy is only about hour and a half, plus time for drains insertion. So you will not be able to do it by chemotherapy. And PPAC is only administration of aerosol. You don't resect anything. You just administer aerosol into the abdominal cavity, and you hope that the aerosol containing cytostatic will improve the situation.
So in your procedure, you did it after doing operation and post-operatively putting the drain and doing this. In most of the cases, as you told, there could be adhesions or lesions. You have to remove part of intestine in some of the cases. So that it can be done by interventional radiologists under image guided.
You mean like what? Removal of
If there are adhesions or something, some area, some loculated area where this HIPEC cannot be reached. So that you cannot estimate on.
No, but you have to release all the adhesions in the beginning of your procedure. That's what you do. You need to have access to the whole abdominal cavity. So actually the first step is a complete release of all abdominal adhesions to create one single big space. Because, for example, in mesothelioma, which has a predilection to create own adhesions because, you know, it's a viscous fluid and there are membranes there, you have to release everything because the cytostatics should circulate freely around the whole abdomen. That's one of essential success predicaments.
Yeah, true. That is the essential requirement. You have to have the whole areas of intraperitoneal area.
Yeah.
There should be any
I cannot
localization.
say how many of these patients had adhesions, probably many of them, but they did not require any action. So we did not re-explore them. You know, if we don't have clinical symptoms, you don't do anything. You know, only that one patient which I mentioned, which developed complicated, he had symptoms of acute ileus, and for that reason, we had to operate him. All others had a paralytic ileus, which resolved over a few days. And then they could be fed completely normally past the stool. So I don't know how severe adhesions in the end they got.
Okay, any more question? Yes.
Yes, for soft tissue sarcomas, we make decisions on during online Polish multi-center tumor board, which Jan and me participate. For other tumors, we run internal discussion in our department with radiologists, oncologists, so it's like internal tumor board. Well, if it's a true peritoneal carcinomatosis, the lesions involve only peritoneum. And I mean, they can be bulky, but they're bulky outside, they're exophytic. So if you get involvement of the root of the mesentery, it's peritoneal involvement, and you can remove all the peritoneum overlying the mesenteric vessels, you know, and leave them naked. And we do it in some cases when you get extensive involvement of the peritoneum over the root of the mesentery. Well, if you see extensive nodal involvement of retroperitoneal nodes in the vicinity of large vessels or in the vicinity of mesenteric vessels, and we think that cannot be resected during the procedure, then it is a contraindication, and that will be seen on imaging, of course. What you cannot usually see are peritoneal implants unless they are large. If they are large enough, then you will see them. But if they're tiny, you are not able to visualize them.
I would like to thank Dr. Stephens for such inspiring
Okay.
presentations, and I think it requires much more brainstorming. We would like to be know much more about this procedure and would like to participate in this procedure also. Thank you,
Okay,
Dr.
thank you so
Stephens.
much. I really try to persuade you to talk to your adult colleagues and introduce hyperkalemia with the help of adult surgeons. Okay, thank you.
Now, this brings us back to track. So thank you, sir, for informing us about your vast experience in hyper. And now I invite upon Vijay sir, our Professor SGPGMS, to present token of appreciation to our chairperson. Now we move ahead with our next session, which is the tumor board meeting. So I invite upon chairperson, Professor Yan. Kindly stay. Professor Shushmita Bhatnagar, madam. Dr. Rohini Sethi, madam, who is a radiation oncologist from RML Hospital, Lucknow. And Dr. Archana Kumar, madam, who is oncologist from Apollo Hospital, Lucknow. Dr. Sushila Jaiswal, HOD Pathology Department, SGPJMS. Dr. Archana Gupta, HOD Radiology, SGPJMS. And Dr. Avinash D. Gautam, Assistant Professor, Radiology, SGPJMS. Kindly, I request you to join us on this.
Good morning, everyone. I'm Dr. Priya Matthew, Fellow in Pediatric Oncosurgery at SGPGI Lucknow. So we have a 3-year-old girl who presented with low-grade intermittent fever for 10 days, mass in right upper abdomen associated with mild pain for 7 days. So she was symptomatically managed and evaluated in a private hospital. A CECT abdomen was done, which revealed a large heterogeneous right renal mass with IVC extension up to the right atrium. She was then referred to SGPGI. Here in SGPGI, she was afebrile, hemodynamically stable. On palpation, there was a 10 by 10 centimeter abdominal mass, predominantly in the right lumbar region, with extensions to the surrounding region. Her labs were within normal limits, except for serum LDH, which was around 724. So ultrasound was done, followed by CECT abdomen. On coronal and axial view, as you can see, there was a large heterogeneously enhancing solid mass measuring around 10 into 10, 10 into 8.5 by 6 centimeters, which was extending into the renal pelvis. Laterally, it was infiltrating the perirenal fascia with vascular extension into the RRV, proximal LRV, the IVC up to the right atrium. So then the metastatic workup came out negative. We went ahead with USG guided two-cut biopsy, which revealed a triphasic Wilms tumor. So my question is, what should be the next line of treatment in such a scenario?
Can I ask the board why biopsy is required for such a case? But they had gone ahead and done a biopsy. So is biopsy actually required in this case?
Yes. A few questions before. Is that thrombus floating in the right atrium or not? Is the blood flow feedback to the heart correct?
It was not free-floating. It was stuck to the right atrial wall. And the blood flow was correct to the heart.
Yeah,
There were collaterals which were developed.
Because it depends on those factors, whether you go in emergency with cardio-surgical team or not. If there is no floating thrombus in the atrium, there is a risk of the big pulmonary embolism is limited. And then you should start with preoperative chemotherapy, just the standard way, actinomycin, vincristine. And you assess the patient. We are doing that weekly. With the ultrasound, but the main assessment is after 4 weeks, of course.
So as sir suggested, so NACT was done. So in this particular case, the chemotherapy regimen and the duration of NACT before re-evaluation. That is the next question.
There was a big number extending up to right and taking off right. What's the question is that two-cut biopsy is really needed in this case?
We wouldn't do that. This is a typical age, typical localization, and typical form of Wilms tumor with thrombus. But it is never mistake. It is never a mistake. You had the right to do that.
It doesn't occur. So, though I do biopsy in every patient, but for something like this, I may avoid. No, sir. I agree. I have operated. There was a big mass that rising looks rising from upper colon for right and involving the liver. Middle hepatic vein, there was trauma, and right hepatic vein was there was trauma. And it actually I think retroperitoneum involving that role of kidney, liver, and tumor extending up to real liver cancer. And alpha fetoprotein was highly rare in 6,000. We have going to show in process. And it was came out, sir, initially I thought it was a Wilms tumor, then we, after tumor marker, we thought it is a hepatoblastoma, then fluke and biopsy. We had given 2 cycle of Wilms tumor, which took fluke and biopsy scores from renal tissue. So we give 2 cycle of chemotherapy, radiotherapy, that not responded. We again went back to the biopsy, then our radiologists, they are very clear. They show if there is IgG thrombus, there is hepatic thrombus, and it's going to up to atria, but there is no thrombus in renal. So that was very difficult. We started Bethlehem for germ surgery, and we tremendous result. More than 60% reduction. They all has gone thrombus. So that's why we have gone for COVID vaccine.
So my opinion is when we don't have tumor markers like Wilms tumor, non-Wilms renal tumors don't have tumor markers for no, corroborative diagnosis for as a diagnostic marker, we must have a biopsy. That's what my opinion is.
No, but I don't agree with it. The world literature very clearly shows that for classical age, classical radiological features, and classical feature like IVC thrombus, we have to assume it's Wilms tumor. And a biopsy is done only when there is no response. With the first 4 weeks, as Jan mentioned, for first 4 weeks or 6 weeks of chemotherapy, if it is not showing a response, then you do a biopsy. And for a typical renal tumor with IVC thrombus, I won't even do an alpha fetoprotein because it's not there. So, I mean, because we have seen, at least in our center, we have seen patients die because of hemorrhage, because of biopsy. And unfortunately, when these are done, and then they come in the night, the patient is bleeding, do something, it's very difficult to do anything at that point of time. So for one odd case we get in our, whole series of patients over years, we cannot justify saying that we should advise biopsy for all the patients. So I think the message should be very clear that if somebody is doing this, okay. But as a teaching point, we do not need biopsy for typical renal tumors. And the only thing that the UK group said that they are doing 6 core biopsies is because they wanted tissue upfront for biological studies. In India, if we are not doing biological studies, then why do we need a biopsy for?
One thing which again, I do really biopsy all the time. And in the world literature, even the umbrella protocol reports that whenever they do it, of course, they have got indications that mentioned yesterday. The complication rate is only 1.6%. And if you really go into the literature, I mean, I haven't heard this before, but no death is reported. There are 2 fact differences are mentioned, but in both the cases, I mean, I went to look through those 2 papers. They were both done transperitoneally and not through the retroperitoneal route. So, I mean, I don't think. I think
We should first answer the first question.
So
Is it required?
The question is located in a different place. Once you do TrueCut, you wait the results about a week, because this is regular histology. Once you decide that you have a diagnosis, you start right now with chemotherapy. So we gain a week time.
So we will use about, I mean, our center about 5-7 days, sure. Waiting for the biopsy report.
But Dr. Yogesh, I think what Jan has pointed out is very important, the time duration. In a busy institutional practice like in AIMS, we would get a 2 or 3 weeks date for the biopsy. This biopsy actually should safely be done under GA. So you are going to wait for that 3 or 4 weeks and then another week for the biopsy report. I think it's not required. And so the first question is, why are we doing it? And then we can talk about the, how to do it and what is safe.
So it's always one second. It's always a dilemma. If we give chemotherapy and that doesn't work, we give 4 cycles of chemotherapy, which is a toxic therapy, and then we biopsy to diagnose. We always have to weigh.
No, I
which
don't agree with
situation.
that. Dr. Sushmita,
to create this dilemma, we are creating this dilemma. The world literature is very clear that the biopsy is not required. And if you say that legally, how are we correct in giving chemotherapy without a biopsy? It's not required because the world literature shows so.
So let's
Yeah.
hear from Piotr as well as his
I
opinion.
fully support what was said. In Europe, nobody would do the biopsy in this case. You do the biopsy only when you have critical doubts. Okay? Like in this case, you mentioned, yes, I will do the biopsy. That was a different thing. That was the case when you had elevated doubts. You took the you could have liver tumor, you could have.
Yes.
The liver, renal thing was not developed, also the thrombus was not starting there. So obviously there were doubts and biopsy was fully justified. But these are unusual situations. And if you do the biopsy, you always do it from the back, from the loin with true cut, in order to minimize the seeding and to get good, large cores of the tissue.
I have a patient that will. Entire kidney being replaced with the renal tumor, very large, biopsy done, WT197. So now they told me that we can't give you a definite report, but it's probably not Wills tumor. So in all kinds of situations, as I said, in 2008, when I started with biopsies, 50% of my tumors were LWRT. I mean, we did not have any advantage of giving NSCT for Wills tumor. And in our situation, I mean, like James, we get the biopsy done the very next morning. And, they said, yes, we have to lose about 5 days before the report.
So I think,
So,
for the trainees and younger consultants, the question is very clear. If you have imaging typical of Wilms and the age group typical for Wilms, will you do a biopsy or not? I think Dr. Sandeep has quoted literature. So they will not do it. We also don't do it if it is very typical and the age group is typical. But there are conditions where you may do it. So I think we have a consensus on that. So we can move to the next question maybe. For the lack of
Just
time.
very last remark after the biopsy, you can expect only an answer, Wilms tumor or not. You can count on specifying the subtype because tumor is heterogeneous. Even if you have some anaplastic cells, that does not mean that this is diffuse anaplasia. So information is limited.
Yes. Agreed, sir.
I think the literature says you're wrong 5% of the time if you don't do a biopsy and start the chemotherapy. So the literature says the figure is about 5%.
No,
if
but
I'm,
even
if I'm,
that 5%, it is only 1%, which is a benign. So you will be
Yes,
wrong
yes.
because it is a rhabdoid tumor or a CCS,
Yeah.
but it's still a malignant.
still
tumor.
benign.
So I would like to highlight which we are missing the point, which is a question here, which Yan already mentioned. NACT or surgery first. So he mentioned a condition in this kind of a case where you would go for urgent surgery. And I don't know whether the people picked up. If the atrial thrombus is free and floating, there is a high risk of it getting detached and going and obstructing the right ventricular outflow or giving a large pulmonary embolus. So in that situation, it is an urgent kind of situation where we should go with the CTVS people and, at least remove that thrombus.
Yes.
If it's a fixed thrombus, which you mentioned,
Yes,
then obviously chemotherapy.
yes.
So,
Can
Archana
I-
ma'am, what
can I
kind of
interrupt?
chemotherapy you will suggest?
There is also rare report of Wilms tumor producing alpha beta. The Journal of Case Reports Pediatrics. So this is very rare, but sometimes Wilms tumor may produce alpha beta.
That was normal, sir. In this case.
I don't know. But probably.
Yeah. Archana ma'am,
So what is your next question?
is it chemotherapy?
Chemotherapy.
What kind of chemotherapy, ma'am?
What chemotherapy, what duration?
Duration, yes.
When will you reevaluate?
I would definitely like to give chemotherapy upfront because of the reason that we don't want to delay giving chemotherapy because it may regress the thrombus itself. And if you have a free floating thrombus, it may give rise to so many complications. And we don't want to wait for so many days. So I would like to give a 3-drug treatment right up front for a Wilms tumor. And it definitely does take care of the thrombus itself in a large number of instances.
How many
I'm
weeks, ma'am?
sorry, I'm
How
sorry.
many?
Should be qualified first. It is free floating or it is attached to the IVC.
And can you really qualify on imaging? I don't think so.
Very difficult.
Very difficult on, Sandeep sir, can we really qualify it on imaging? I don't think so.
The problem is, what protocol are you following?
Probably you have
No, there's
you have to
very
consider both CT reports and probably Doppler also at the same time.
Doppler and echo, everything was done.
We have Avinash or Archana, madam.
I'm sorry, once you have very high thrombus, you should avoid anthracyclines. So not three-track regimen, because later on you will probably have to use radiation therapy up to right atrium and heart. So avoid anthracyclines in such cases. Two-drug treatment would be enough. If it's not effective, you switch to VP16 carb. So that's the way to go, and avoid anthracyclines. Three-drug regimen is not justified here.
So Jan, again, there's a difference. The COG protocol mentions what Dr. Archana has mentioned, 3 drugs with anthracycline and for 6 weeks. The SIO protocol mentions 2 drugs for 4 weeks and reassess, and then add VP16 carboplatin. But our experience has been with 3 drugs, including doxorubicin for a long series, large number of cases. We never had a problem. We usually reassess at 6 weeks, and then from there we take it on.
So we can listen.
The COG protocol also says that if the thrombus is infrahepatic, below the hepatic veins, then you can go for upfront surgery. That is the standard COG protocol. But at least at our center, we have given neoadjuvant chemotherapy for all IVC thrombus, no matter what is the extent of it. So whether it is going above the hepatic veins or below the hepatic veins, we would give NACT for all. And in our experience, 25% of these cases are complete resolution of the thrombus. So they don't need any procedure for the K1.
So how to reevaluate the thrombus? Maybe we can have the advisors comment.
So I just wanted to talk about protocol. Institutes don't follow as a routine policy a protocol. They individualize as per patients. Like in one patient, they would use COG protocol. That is what my.
Why do you think so?
That it's not about your institute only. I've seen many. It's not about Tata also, because you all have a structure. But many places there is sometimes they will use PSYOP protocol, sometimes they will
No,
use
but institutional protocols are fixed, ma'am. It's not like we sometimes use COG or sometimes use PSYOP.
I'm not saying you.
No, but their protocol is fixed, sir. They don't jump from COG to PSYOP.
No,
Huh.
Dr. Yogesh, I think, no.
Oh, that is okay. That is okay. What you mean saying is sometimes we use COG, sometimes PSYOP. I don't think so. You can do
There
that.
are institutes. I am aware. That is why I am saying this. There are places where individual patient receives a protocol as per that patient. It's not a routine.
Understand, our protocol is our protocol. And I say that it is a hybrid protocol, but we know what to do for which patient. It is not, we are following the philosophy of PSYOP of giving neoadjuvant chemotherapy, but we have indications for that. So it is not that I choose. The indications are there for giving neoadjuvant chemotherapy, and indications are there for which we can go upfront for surgery also. So it's our protocol, which is, but the protocol chemotherapy, the format of chemotherapy is COG. The philosophy is there of PSYOP that we don't go for upfront surgery for all patients. We don't do that because we waste OT time. So it is called AHWT99 protocol, which has the format of the COG protocol, but we do the philosophy of, but it's not individualized. It is not, for this patient, I do.
Not in your center.
No, chemotherapy protocol has to be fixed. If the institution is a large volume, if you're doing 2 cases in a year, then it doesn't matter.
I think that is so in most centers, PGI, Nitin, Sandeep,
I think it
you can have
matters.
comments on protocols for chemotherapy. I think it's fixed everywhere.
Protocol is not only for chemotherapy, it is about the treatment plan, the entire protocol.
We do a PSYOP.
It's not only chemotherapy.
Okay.
So the protocol that AIMS is using cannot say that I'm using SAP or I'm using.
No, that's fine, sir. That's AIMS 91 protocol. That's fine. Yeah.
And there are a lot of institutions where if there is small vein tumor, they will go for COG way and maybe do the whole thing COG way itself. And there are others where they will find a large tumor. And I can tell you, SAP too, if I'm not wrong, they had said that given time that size should not decide whether you should do NACT or not do NACT. And they have proved in the data way back in seventies that if you do not give NACT, the chances of rupture are more even in a small tumor. So the tumor, of course, there are lots of studies and I can even quote those references where they have put it that more than 10 centimeter, blah, 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 the chances of rupture are more. If I say hybrid in a way, so nothing wrong about it because in the chosen some good things from COG.
Agreed, sir.
And I believe the way we are converging in 10 years, we will have one protocol really for all tumors, which will have the best of COG and best of SIOP eventually.
Yes. Priya, proceed.
So if you look, if
Thrombus, and Bhasan got up and said that thrombus was the atrial junction. So
No. Sir, that was different case. That was germ cell tumor.
if you look what Americans are doing now, you will find out that they give preoperative chemotherapy in 25% of cases now. So that's a big group in CW, in COG, which is getting chemotherapy. This is one point. And the second point, in this early study by SIOP, which differentiated small and big tumors, again, there was a benefit of pretreating even small tumors.
I think we have 4 interesting cases. Let's go ahead with the case.
Take up 4.
Yeah,
We will have to limit them. I think 3 should be good
but
enough.
at least let's
Yeah.
move on in this case at least. Like we can see the CT after the Priya. So tell what chemotherapy was given and when was the CT done?
So moving on to the non-contrast sections, these are the axial sections. Here we can see that there is heterogeneously hypotense lesion in the right kidney with multiple small septae. There is no evidence of any calcification or fat density within the lesion. So to characterize it.
Can you please start the video again?
Yes, sir.
So this is the non-contrast axial
So
section.
this is the
Same patient.
CT scan of the patient post chemotherapy. So moving on to the non-contrast sections, these are the axial sections. Here we can see that there is heterogeneously hypotense lesion in the right kidney with multiple small septae. There is no evidence of any calcification or fat density within the lesion. So to characterize it further, we are moving on to the venous case image. In the venous case image, we can see that there is heterogeneous kind of enhancement present within the lesion, more in the septum, not much in the solid part. Then this tumor is seen extending along the right renal vein here, as we can see, and it is extending into the IVC. The IVC is distended and there is heterogeneous kind of enhancement which is present inside the IVC. So to compare, is present in the IVC. So tracing the IVC superiorly as we're coming, so this is the level of the hepatic vein ostia. So it is also involved, and moving further superiorly, we are able to see that this tumor is extending up to the level of RA, and posteriorly it is not separate from the wall of the RA. As far as the hepatic
Apart from this, what we were able to appreciate was that there was tumor thrombus which was reaching and involving the hepatic vein ostia also. Probably a delayed scan would have been much better because that would have been able to tell us the involvement of hepatic veins more. And apart from that, we were also able to appreciate that there was heterogeneous enhancement in the liver parenchyma, which was probably because of slow venous drainage or absent venous drainage. And apart from that, there was one more finding that the tumor thrombus was also extending into the initial or the proximal part of the left renal vein as well, which was not recorded in this video, I think.
Yeah, so we have a thrombus involving the ostia reaching till the atriocaval junction. So in the right atrium. So what do we want to give do next? Do we want to give more chemo or operate the child? If you want to operate the child, what should be the surgical approach? So those are the questions.
First of all, we have very nice response from the tumor, also from the thrombus. However, he's not going down. It's just smaller. Anyway, you will have the thrombus sticking to the vascular wall after chemotherapy. That's normal. I would still try to continue with chemotherapy. If the response were not so good, we would switch to VP carbo, but the response is good. I will just continue for next 4 weeks and then go for surgery.
Yeah.
So the surgical dilemmas faced by the surgeons, the approach to be taken in this case. It should be the tumor first or the thrombus first.
Next.
No. Just one word to add to my previous comment. If we prolong chemotherapy, we can find out later on that thrombus is tumor cell negative. We can also add some heparin to the treatment because the part of the thrombus which is composed only from the blood clots can regress easier. So some centers are giving also heparin. There is nothing to evidence-based to say that it is effective, but some believe in that. Regarding those questions, we are always trying to do everything at the same session. So thrombus with cardiovascular team, with cardiopulmonary bypass, because you have a thrombus in the right atrium. So you must be ready with the machine. No, even not ready. You have installed the machine. Yeah. And then you are safe.
I'd like to add in that when we do this kind of a case at BGI, so the cardiac surgeons always insist on a CT pulmonary angio. So I think that is an important part of the investigation to know that there should not be any thrombus which, breaks and goes into the pulmonary system. So that's an important take home, I think, which needs to be done in an area where this particular thrombus has come. And we also do both ends at the same time without the bypass initially.
Many times during chemotherapy and before surgery. It was everything was done. My question is if tumor is responded, it becomes decrease in size, but thrombus is still persistent there. So we had to operate it. There is no dilemma on it. After 6 cycles, we plan to do for surgery. So we cardiac bypass. So we take it with our colleagues, we mobilize that tumor. Then how we approach to that problem? This is the most important. Initially, I thought I can take it by giving thyroid and it can come. But as radiologist said, there was not protein thrombus in the atrium. It was essentially a wall of right atrium. And during intraoperative, we need to cut the part of right atrium, part of some IBC. Later it was very cardiac. So how we can approach
bypass before and do pulmonary artery clamping first, or we should try to remove by IVC. If it doesn't come, then we call a cardiac surgeons.
I think
my question is
Jan answered it initially also. I think the patient has to be put on bypass first. So we usually do a big incision, sternotomy, going on in the abdomen, ready, and then put the patient on bypass, and then start mobilizing the tumor and the thrombus and everything. But patient has to be put on bypass first, because that is the safest way. Whether you clamp the pulmonary artery or not is something secondary. So the safest way is to put the patient on bypass, go ahead. That is what Jan mentioned.
No, I think, sir,
ready.
I think Dr. Basant is saying if it is floating, can you just open the IVC and pull it? Is it possible?
By this time, after giving chemotherapy,
Yeah,
nothing is.
it would have fibrosed and stuck to the atrium. So I think you should always put the patient on a bypass, and that is much safer.
In such a high case, you cannot believe that you classically take off the cloth from down. So that's impossible.
Correct.
So you have to put a bypass, you have to remove the thrombus from right atrium and as low as possible, then open cava down and remove that. Please notice that at that time you have fully heparinized patient. So we finished the cardiac part of surgery, we still keep a bypass, and then we convert heparinization and resect a tumor. And it is not realistic that you will remove thrombus after chemotherapy in one piece. That's
Correct.
practically impossible. You will have to use a scissors, you have to go in sharp because it will be sticking to the wall. And that's why my comment on anthracyclines, because later on you will most likely have to irradiate this patient because it will be R1 resection. And radiotherapy to the heart plus anthracycline to the heart is nothing good.
Is there, Ankur, may
Yeah, sure.
So there is one question which I always had and I've asked in a couple of meetings and did not get an answer. So when we put a patient on bypass, generally the trend of the cardiac surgeons is they use a cell saver. They kind of recirculate the blood which they're losing into the bypass machine, and so that there is less of blood loss. So having said that, in a situation of a malignancy, what is your experience, Dr. Yan, about using a cell saver? Should you use it? Should you not? Because the cardiac surgeons are quite adamant that it's their system. They use it commonly. So is there any oncological disadvantage to this thing, which is, it's not there in the literature?
Yes, this is a classical comment, but I would say simply we have no other choice. There's no other technical possibility. Of course, this blood is filtered, but you can say what is bigger, red blood cell or tumor cell? I don't know. So filtering, gene filtering is nothing, it's impossible.
Another thing, Jan, which I can comment here is that our cardiac surgeons have added that for most of these cases, they do a beating heart. So they will not paralyze, stop the heart, and they will make sure that there is no persistent foramen ovale or anything by intraoperative esophagogram, esophagus, this ultrasound. And then they would do a beating heart. So that increases the morbidity even further. So they don't have to stop the heart, they don't have to start the heart, it is beating heart and use the cell.
Yes, we are operating on beating heart when the thrombus is above liver and not in the heart. If they have to open the heart, even atrium, they have to stop it.
You can proceed. Yeah, proceed.
It's a NACT. Child underwent sternotomy plus right nephrorectomy, cavotomy, thrombectomy from the IVC and right atrium with pericardial patch repair of part of IVC and right atrium. So this is the resected specimen with the thrombus.
So what was the response in the tumor post 6 cycles?
Ma'am, the size of the primary, it was the same, but the tumor thrombus in the IVC that shrunk as per the imaging. So
That CT we saw was after
That was
chemo.
after.
chemo.
Okay.
After chemo.
So the final HPE report was thrice-facing Wilms tumor with the blastomal component 15 to 20% with favorable histology.
Histology of the thrombus?
It showed tumor thrombus. Yes, sir.
In the thrombus, whatever they have sent labeled as thrombus, it has showed all the 3 components: the blastomal component, epithelial component in form of tubules, and the stromal component. So it is consistent with the.
In my experience, is very uncommon because most of it, at least in our setup, comes as fibrotic and no tumor thrombus. But we do get tumor positive thrombus also.
So if the thrombus, sir, was positive and we have done a cavectomy, and as Dr. Yan said, so it will become an R1 resection, not R0.
That's what he said.
Yes.
The RT.
So we have to keep that in mind. And the thrombus did not show the tumor, then can we call it R0? Dr. Yan, what's your thought about that?
This is always a great question. What we believe. Because if there is no tumor cells in a thrombus, that does not mean that there is no cells in tumor thrombus. That
Correct.
means that pathologists did not see them. And that means that either there is no tumor cells or there are tumor cells, but very few and were not discovered. So my opinion is to consider each thrombus tumor positive, and maybe only doses of radiation therapy could differ.
Yeah. So still treat it as microscopic residue positive. Yeah. Yes. Yes.
How many?
No, is it still possible that cells are there and we have missed
We have
it?
taken only one section. In one section only, we saw these all the 3 components.
Okay. So we will go ahead thinking that it is microscopic residual positive and then treat it further. Okay, next slide.
On post-operative day 15, the child underwent post-operative doctoral study. We went ahead with a CT angio. Both of them showed thrombus in the inferior part of intrahepatic IVC.
Next slide.
So, sir, next question is how do we approach this new finding?
My question is that, sir, there was initial phase of Doppler in ultrasound, a post-operative period. It was absolutely all right. And during the thrombectomy, we have cleared the opposite renal vein, IVC, and atrium. At that time, there was flow in the Doppler. It was little bit slow, but there was flow. And initial 15 days, there was no thrombus at all. After 15 days, we found a small thrombus in the intrahepatic part of the. Then what is it a tumor thrombus? It is a simple thrombus because of polarization of flow, or and how we can proceed it. We are giving chemotherapy. We should intervene by intervention, radiology, or we should treat slow and
I think you can't, if I may, you cannot go back in and remove that, and it's in a location which cannot be removed. So you have to depend on radiotherapy. That's what I would think you need to do.
Yeah, check which stage and during that period. And what ma'am recommend radiotherapist recommend within how many days radiotherapy is elective, how much load is required.
So now what do? We give chemo to the child once the child recovers and then give RT, or having seen the thrombus, give the RT first and then give the chemo. So yeah. So now there is an added element of this new thrombus in the intrahepatic IVC. If it was not there, within 2 weeks, we would have ideally given an RT and also given the chemo DD4A, we would have continued. But now with this thrombus, any changes in the management?
Results of RT are definitely poor if it is started after 10 days of surgery. So in that light, we have to take other decisions. Thrombus.
This is quite surprising that this thrombus exists intrahepatically after that extensive surgery. Prior to, maybe this is secondary thrombus in the place of stitching the vena cava. Question whether to go back there with surgery or maybe to do PET scanning and check whether it is positive or not, because it is unlikely that a surgeon who was able to remove that difficult thrombus with the tumor together missed the easiest part, in fact. So I think this is a secondary thrombus. I would check with PET-CT. If negative, I would accept the explanation that this is just, let's say, surgical thrombus, not oncological. And regarding postoperative treatment, I would go classically like with stage 3. So AV for 27 weeks, plus radiation therapy. Now we are not using even for stages 3 doxorubicin. There was a last study, 2001, which compared to doxa plus, doxa minus, and there were no big difference. Of course, this is a remake of previous study, but it was better done, and we eliminate doxorubicin in responsive tumors.
Also, ma'am, if you can highlight the side effects of cardiac radiation. Also, you will have to give liver radiation in the area of the liver because there was in the intrahepatic IVC. So, effects of cardiac radiation in children. You can go.
So it is proven that each gray of added dose to the heart increases 7% increase in cardiac events, and the increase in events increases with the passing time. So in children, we have to be extra careful while irradiating heart, and the doses are definitely lower as compared to the adults. The liver doses are also lesser, and what we usually do is around 10 gray to the flank, and then we boost the residual tumor to another 10 gray, around another 10 gray.
because we're giving adriamycin. Yeah. So Sandeep sir, in your experience, like cardiac radiation plus adriamycin in follow-ups, long-term follow-ups has it caused any cardiac dysfunction in these children?
Not really. So in our long-term follow-up of these kind of patients with IVC thrombus who received cardiac radiation, we have not seen the events of, but we don't know what is going to happen after 20, 30 years, because as the age advances, the incidence of cardiomyopathy also increases. So the cardiac dysfunction can be presenting late also, 15 years following the treatment with doxorubicin and radiotherapy also. So we have to really follow up so we are doing that. We don't know. No, lesser. It's according to the protocol.
It is.
But total dose will be about 180 milligram per meter square. Total doxorubicin dose. The cardiotoxicity usually is reported at around 350 milligram per meter square, but then it can happen earlier also. So we don't know.
Yes. My question to Archana ma'am, we should go for 3-drug regime chemotherapy or we need to change it? Yeah.
Yeah, not very sure about what was there in the initial thing. I was going to.
Follow-up plan, ma'am, question written there. After end of therapy. That is same. Ultrasound, X-rays. Okay. Priya, anything else?
Yes.
I have is absolutely similar case with the particularly in the world. The only difference is that there was no atrial thrombus. And I also eventually have landed up having a secondary thrombus. So one thing I'll do, go back home and do a PET scan. But what is the incidence of something like this secondary thrombus happening after a group surgery? How many, if you do 100 such cases, how many cases would you probably see a secondary thrombus like that, which gives you plasma, whether it is a blood thrombus or whether it is actually a tumor thrombus? And tumor thrombus would come that big size within a couple of days. I mean, so, and we didn't give heparin. But whether there's any role of giving heparin after such surgeries, so these are the two questions.
I can only say something about the secondary thrombus. We had that after operations on similar cases, but usually much later in the follow-up. Even after the treatment, we had some problems with thrombosis, with rethrombosis. It was usually treated conservatively with heparin and ended up well, but we are always doing PET scanning to check activity. So this is a classical complication of vascular surgery, rethrombosis. That's the classics. Why should not happen in oncology? That happens in oncology.
Surgeries also when we do shunt surgeries, we have thrombus even when heparin is given, heparin followed by warfarin is given over a longer period, still we have thrombosis. Probably this is a secondary thrombus. That is what I've been thinking since we are discussing this case. But as he rightly said, we need to be sure that this is secondary thrombus and we cannot plan our treatment based on assumptions.
Okay. No, ma'am, CT for detail of this patient I'm informing. Child is absolutely all right. She is dated for PET CT, as sir saying, and she is coming today to meet us in the last session. And what need to do? What is is there any chance of this dislodgement or something? We are worried. We will, before going to PET CT scan, if it dislodges and causes any embolization. So we should give heparin or not?
We can move to the next case. Yeah, I think Priya.
Just wanted to add that the cardiac toxicity that would be caused because of radiation, where radiation would be a culprit, we'll get to see only maybe 2 decades later when the child is an adult. So that's one thing. So we can't sort of ignore it at any point in time. But I'm not a surgeon. So what my question or query to you would be that in such a case where the thrombus is reaching up to the right atrium, would you like to place a clip at the cranial edge that might help us a little in designing our portals when we are planning radiotherapy for the child?
So we are placing clips on tumor bed, at least in the abdomen. So ma'am is asking whether on the cardiac end we place clips. I have no idea. So
Cardiac surgeons usually don't use any clips, but still one word. The technique looks like opening of the heart, right atrium, then open infrahepatic vena cava. Sometimes a little bit of retrohepatic. The rest of vena cava is not open. We try to reach the thrombus with scissors or clamps or whatever. And this rethrombus is located exactly in the place when cavotomy was done. Another factor 4.
Right. Thank you. So thank you. Next case.
Dr. Ranga.
Who's presenting? I think Ames case. Yeah.
So may I request time management? Because
How much time we have for this case? I think 20 minutes more. How much time we have? 20 minutes this case, and then we'll move to the next session. Yeah. Okay.
Good morning, respected chairperson, teachers, and today we will be discussing a 2-year-old male child, resident of Bihar, who presented to us with incidentally detected abdominal mass. So, child was apparently well till 4 months of age when he was incidentally diagnosed to have a left abdominal mass on ultrasound. While child was admitted for fever and URI, there was no features of abdominal distension, recurrent fever, vomiting, respiratory distress, or lump anywhere in body. No urinary complaints or hematuria was there. No history of seizure, difficulty walking or delayed development. No history of constipation or loss of appetite. No history of voice change or hair growth in axillary, pubic area or face. No history of easy bruisability. No history of recurrent infections. And no history of headache, blurring of vision or palpitation. There was no significant family history and no significant past history. On examination, the general condition and vitals were normal. There were no neurocutaneous markers, and per abdomen was soft with no lump palpable and no tenderness, and bowel sounds were normal. Other systemic examination turned out to be normal. On routine blood investigations, the hemogram and RFT were normal, and urinary VMA and AFP was also normal. Ultrasound, the patient presented with an ultrasound done elsewhere at 4 months of age, which indicated query a left kidney mass or a left suprarenal mass. When he presented to us, he was for 6 months of age, and a CCT abdomen was done in September 22, which revealed a possibility of left cystic neuroblastoma or query adrenal hemorrhage with size of 8.5 into 7.8 into 6.5 centimeters. So this was the CT scan, and here it shows a large 8.5 centimeters mass in the left suprarenal area. And another notable finding in this CT scan is the compressed left kidney, as can be seen in this image. So in view of a left suprarenal mass, we proceeded with a metastatic workup. Bone marrow aspiration revealed no evidence of metastasis. Skeletal survey, including skull, spine, pelvis, and limbs, were normal. Technetium MDP bone scan revealed no metastasis, and ultrasound guided FNAC was attempted by us, which was inconclusive. So this is MDP bone scan, which shows no evidence of metastasis. MIBG whole body scan was also performed, and no pathological uptake is seen in this image. As patient was clinically asymptomatic and investigations, including MIBG and metastatic workup were normal, he was kept on active surveillance and planned for reconstruction after 6 months. So, requesting for
Really appreciate the person who did the primary ultrasound abdomen at 4 months of age when the child was admitted with URI. Who does abdominal ultrasound when URI, patient presents with URI? So it is great because we picked up something. And I also want to know what was the difference between the findings at 4 months and 6 months?
Actually, at 4 months, the ultrasound was from another center, so they only mentioned left kidney mass only. So when the patient presented to us at 6 months, we did a preliminary CT scan to better characterize the lesion, which revealed a 8.5 to 6.5 centimeters mass. Just 6 months. Yes, ma'am. 6 months. Now the child is 2 years old.
What are the differences that we would think of at presenting at such a young age with a cystic mass in the suprarenal area, and how should we have proceeded?
I think that we would really need an MRI for that, and to have a look on the. I think that diagnostics is incomplete yet. It is something only little active, not neuroblastoma, overactive type, very kystic. I would suggest to do MRI, because at MRI we will get nice coronal scan, nice frontal scan. We will be able to see better the relationships to the surroundings, better than on a CT, especially that this CT was done in the low radiation mode because of age. So you don't have very high resolution. So that's my suggestion. And the size is quite impressive. It is not a small thing, and that's why I would not think about a simple hemorrhage to the adrenals. That could be 2 centimeters big, but not as big as that one.
Yeah, so large cystic mass, how many of us will biopsy this tumor?
Well, I have a question. Is the mass septated? Is it multi-compartmental?
So it was homogeneously cystic only.
Yeah, but
No
it's
solid
one big
component.
cyst or several cysts?
So single cyst only. There was no heterogeneous component or solid components in this CT scan at least.
Maybe show the
Because
scan
it
again.
can be a mesenteric cyst, it can be lymphatic malformation. It doesn't have to be anything oncologic, you know. So I think probably myself, I wouldn't just follow the patient without diagnosis. Like Jan, I mean, we would try to do MRI, or we would try to do maybe more detailed ultrasound. I think it's a big mass in the end.
I would like to add something. Actually, there is no complete imaging available here. You have shown one scan only that is showing, in fact, that image is not showing the kidney also. Posteriorly, some tissue is seen, but that is not kidney. So we cannot see separately the adrenal gland on the left side also. So you have to have the complete image.
Wrong CT scan. The entire
Yeah.
CT scan with coronal and sagittal sections.
Yeah, CT scan is nowadays quite enough because we have multi-slice CT, we can do triple phase CT, and CT can demonstrate most of the thing. In fact, we have not tried to sort out whether they are calcifications or not. So the single image is not sufficient. You have to have the complete
So what was the status of the left kidney? Anjan.
Anjan will tell.
Yeah.
No, you should have add up some sagittal coronal sections where you can show the kidney push downward and the whole set of tumor itself. And patient was
And what about the left kidney, Anjan? Left. was separate. So that is a very crucial information, I think, as ma'am is saying.
When left adrenal gland is not seen separately from the lesion and the left kidney is pushed downward or posteriorly, so it should be separate. So it's definitely suprarenal. Now it comes about the differential diagnosis.
Yes.
In suprarenal, in this age, if it could have been adrenal hemorrhages or something, so there should be something like it could be acute, subacute, or chronic hemorrhage. So that has to be correlated with the presentation of the clinical presentation of the kid. And that can
So
be
adrenal hemorrhage, ma'am, can it be completely cystic without loculi or septae or echogenic debris?
in that
Can it
case,
be?
in that case, mostly the size is the shape is maintained, size
Yes.
can be enlarged, but depending on the stage of the hemorrhage, it could be acute, subacute, or chronic. So in all three phases, you can see temporal resolution of the hematoma. That can very well be differentiated on CT also, but better is MRI. And otherwise, the presentation, clinical presentation of the kid also, whether he is having adrenal insufficiency or something, that I think it was not there.
Yeah.
And nephroblastoma, neuroblastoma can be cystic, associated with calcifications and all, and that can insunate between the adjacent structures, displacement and all. Here, only the kidney is displaced downward and posteriorly. So adrenal hemorrhage can very well be differentiated from tumors.
One extra questions. What was the Hansfield score of the liquid inside?
Sorry.
Hansfield units score.
Hounsfield units.
It must be like if she thinks this.
If this is 30 to 40, this is a blood. If this is 20 or 10, this is just the
So it appears to
fluid.
be here less than 20.
Yeah.
Fluid density. Yeah. Mike. Yeah.
Did you look at the flow by Doppler in the mass? Because a neuroblastoma is more likely to have a blood flow by color Doppler, whereas cystic hemorrhage will not be having a blood flow likely in that. Also, has it become bigger or smaller? What has happened? You could have.
that question.
That is very important.
Is required actually.
From 6 months to 2 years,
Yes, ma'am,
what
I'll
has
be-
happened to that?
I'll be coming to that.
Also, like, I would have probably admitted the child catheterized and sent a 24-hour patient. That is non-invasive. You're saying
Urinary VMA was normal, sir. Yes, yes.
I mean, neuroblastoma diagnosis is rather unlikely here. You know, of course, it may happen. You have a cystic neuroblastoma, but it's pretty unusual. You don't have MIBG is negative. You don't have catecholamines, yes, I presume, or of HBA or VMA. So maybe it's a benign lesion, you know, and really MRI is essential. You have to remember that in small children, young infants, neonates, resolution of CT is very limited. It's really limited, you know, because they have little fat. There is no good separation of various structures. And especially in cystic lesions, MRI is indispensable, really.
So the child was kept on active surveillance, and at 1 year of age, ultrasound abdomen was repeated, which revealed more solid component in the left suprarenal mass. However, CCT was further done, and it reported a decrease in size of mass to 5.9 into 5.6 into 4.5 centimeters. And it was a left suprarenal solid cystic mass, which had increase in solid components. As solid components had increased in mass, in view of suspicion of malignancy, MIBG was repeated. And on repeat MIBG, no pathological uptake was again seen. So this was a CT scan which was repeated, and it showed a increase in solid components. And this is the MIBG which shows no uptake. Core biopsy was attempted at this point of time, but could not be done as solid components could not be localized from the mass. After 2 months, we did an MRI abdomen to better characterize the lesion, and it showed a 5.5 into 6 into 5.2 centimeters left suprarenal solid cystic mass encasing aorta and left fetal pedicle with more than 180 degrees of circumference with small and compressed left kidney. An FDG PET was also done at this point of time, which revealed a 5.2 into 5.2 into 4 centimeters mass with necrotic areas with query minimal peripheral metabolic activity. So this is the MRI which was done at 1 year, 2 months of age. This is the mass which can be seen. And on coronal section, we can see the mass. This was the FDG PET, which showed only query minimal peripheral activity and no other pathological uptake. So requesting your views on the same.
I think instead of FDG PET, we could have done a Dotanok PET. So what is the sensitivity of Dotanok PET as compared to MIBG? It has come up in recent years. So we are using Dotanok PET a lot because the MIBG study happens once a month. So the dates for MIBG are really long at SGPGI. But the Dotanok PET, we are able to do at least every second week. So
Dotanok PET is more specific for pheochromocytoma and other endocrine tumors, and other than this neuroblastoma. For neuroblastoma,
No,
it is more sensitive than the Dotanok PET.
But we are using.
I'm not sure of that, sir.
We have done in our
FDG versus Dotanok, you're saying FDG is more sensitive?
for neuroblastoma.
MIBG. No, sir is saying about FDG, you're saying about
And
MIBG.
FDG
Okay.
will take activity of any hyperactivity.
Yeah, exactly.
It will not be specific, but will be sensitive to pick up. But Dotanok PET CT is more specific for PO.
But it picks up neuroblastoma brilliantly. We have seen that in many cases now. So and there is literature for that. So what I was asking is whether the sensitivity is as much as MIBG. I don't have the answer to that.
In our experience, we've used DOTA-DATE, and that has got given over the last 7-8 years, has brilliantly worked for neuroblastomas because of the logistic problems of MIBG. And we actually don't even get it once a month. We don't
Yes.
get MIBG because of the logistic issues. So DOTA-DATE, every PET scan is done as a routine part of our workup for neuroblastoma with brilliant results. Last 7-8 years, maybe.
I agree with that. Dotanok has been known to give good results. Now, comparison between these two, I'm not aware if there are any studies.
Ma'am, there are many studies in.
These are anecdotal.
No, sir. There are studies. There is I can share a study in the journal of.
The issue is that radioactive material of MIBG is not easily available.
Yes, so
now I don't think we should even look at comparison as to which is better because the other one is not really available as such.
Yes.
But as per CT scan, it was cystic. Earlier, totally cystic. Now there are more solid components, which is.
So even if a neuroblastoma matures, still MIBG will pick it up if it is from sympathetic ganglia. Even if it becomes a ganglioneuroma, it will become positive. So MIBG will be negative in about 10 to 15% when it is from the cholinergic ganglia. So is that a case where it is from the cholinergic ganglia? Could be. Anjan? That's what I'm saying. So 10% is negative from non-sympathetic ganglia. So it can be one of those cases. We don't know. Yes. Postgan.
In preganglion, maybe paraventricular, there may be some cells. But on adrenal, there is no cholinergic cell. That's
Correct. So I think what should be the next point in this case?
One question is that initially when biopsy was done, that time it was some fluid must have been aspirated, right? Because it was totally cystic. But there was no solid component in the first CT. So that time was aspiration of fluid attempted and studied. Oh, that would be very difficult. Yeah. That would be very difficult.
Yeah, but now enough of solid component is there. I would re-biopsy this case, actually.
They've done it, but
Sir?
even then it is,
But that should be, matlab, we need tissue diagnosis in this case now.
so the only way to have a tissue diagnosis is to excise the mass. Excise, either open, laparoscopy, robotic, whichever method. What's your opinion?
We have one very important factor, the size of this tumor decreases. So this is not logical to have something very aggressive. And I was a little bit against the idea that this is adrenal hematoma at the beginning, because I've never seen that big hematoma. And we saw a lot of those, but maybe it's something which now organizes, and you can very easily imagine that the hematoma is a little bit encasing, surrounding also the vessels. So for me, this is not independent, sure proof of malignancy. But maybe a TrueCut now would be justified just to know what is this. It may not be malignant disease, but we still cannot exclude that. And not only malignancies are dangerous for kids. And I see that what was written here, that TrueCut could not be done because a solid part could not be identified. I'm sorry, but I strongly believe in that. I think that maybe other machine, maybe other sonographies, but it must be identified.
Yeah, true. It's not possible.
Or CT guide.
But it is very well seen on the imaging. So
Yeah.
CT guided biopsy.
Maybe a technical point at
Right.
technical point at one attempt, you can go in again. Yeah, maybe a CT guided biopsy again. Because the problem of waiting is if it encases the vessels completely, and we are just sitting on it and not starting treatment.
It doesn't look difficult. It doesn't look difficult actually. Whatever imaging you have provided, it doesn't look difficult.
I think it is seen on function of the kidney is seen on CT with contrast.
So any other follow-up on this side?
We did a follow-up MRI abdomen after 6 months after 6 months. It showed a 4.9 into 5.3 into 4.4 centimeter solid cystic mass at level of L2, which showed a further 19% reduction in the mass from the initial MRI scan. So at 2 years at 2 years and 3 months of age, the MRI abdomen now showed an increase in size of 6 into 4.7 into 5.2 centimeters left suprarenal mass, which was encasing renal and infrarenal aorta and abutting celiac and phrenic artery origins, spleen, phrenic vessels, the atrophic left kidney, pancreatic tail, and the bowel loops. So now it has shown an increase in the mass by the MRI.
And kidney in this is not very clear.
It is atrophic and
Small thing.
Yeah.
So that's what I'm saying. I mean, when we know the DNS, I mean, do DNS and the function only 5%, 7%, then it's so much easier. Go in and remove everything. Rather than
Next.
Just summarizing the case, so the child presented to us with incidentally detected left suprarenal mass. CT presentation revealed a cystic mass. Metastatic workup and MIBG were normal, and we attempted a corneal biopsy, which was inconclusive, and the patient was then kept on active surveillance. Subsequent follow-up CTs and MRI revealed decrease in size of mass, but increase in solid components. So MIBG was again done, and it was normal, and FDG PET showed only minimal peripheral activity. So the active surveillance was continued. Now the latest MRI after 6 months revealed an increase in size of mass and vascular encasements. So we're requesting your viewpoints on next course of action to intervene also.
I am also concerned, I am saying this to surgeons, I am concerned with the exposure of radiation that this child is getting with repeated CT scans, FDGs, PET and all these things. PET as well, no? PET CT is being done. So radiation is a lot with PET and CT together. So we need to be sensitized to this, that we need to limit the exposure of radiation. Yes, please go ahead.
In the subsequent MRI includes the atrophic left kidney. What was the kidney turn to the left side?
So from the first ECT, only the kidney was atrophic only, from small and atrophic. From the first CT scan, we have known.
Size is definitely between, I don't know whether you mentioned that in ultrasound and all that, but kidney size between. So I suggest the EMS is done, it's not done. What is the part like, you look easier, go and get the mass out, kidney out.
It should be excised.
So as there was an increase in size of mass on MRI abdomen, he was planned for surgery. However, the family was not ready for the same at this point of time. He again developed 2 episodes of abdominal pain in August 24, and then he was planned for definitive surgery and counsel for the same. So we went ahead and excised the mass. So in this image, this is the left suprarenal mass which can be seen, and behind it, it was the aorta and all the abutting, the vessels it was abutting and encasing. So this is the left kidney which was retracted, and the left suprarenal mass was excised, and aorta can be seen behind the mass.
What is a histopath?
As the surgery was.
Yeah, he's revealing it very, very slowly. Like, yeah, that's what I do. Yeah, what? Sorry? Adrenal teratoma. Okay. But provisional diagnosis. Yeah, that might explain a lot of things. Yeah. Encasement.
Learning from this case, in the first place, when we found the 8 centimeter mass, 8 by whatever centimeter mass,
Sometimes.
did not appear like, you know, a pure hemorrhagic tissue. The surgeons go ahead and do a primary resection at that point itself. Or keep waiting for 2-3 years. And then
I think we're seeing more of these masses now because of antenatal diagnosis. All of us are seeing a lot of cystic suprarenal masses in antenatally and then postnatally. I think at least first 6 months we should be conservative. That is what I feel.
so according to Archana ma'am, she has not spoken in the mic, and I don't need to speak in the mic. She says that up to 9 months we should wait. 9 months. Unless it right, increasing in size of comes.
I think time is up and
Can I ask one question? I recently, similar case I was talking about that there was another tumor which was separate from the kidney behind the liver. So I removed that too. And that was also Wilms tumor. So I had gone through the literature. Wilms tumor within the kidney and extrarenal Wilms tumor in the same patient. And I don't know, then.
Quite clear. I don't know why you say the left kidney there. Because atrophic, you are saying one way.
Atrophic left kidney was there. Function was not done.
There is very little time with us. So many people are leaving after 2 o'clock. Yeah, we cannot.
But please take it again, yeah.
So, yes, and of course, there is a possibility of extrarenal Wilms tumor or possibility of renal tumor developing from accessory kidney. But I don't believe your case was completely different, that thing. And but we have a nice discussion, but we have a tumor resected. So what was the pathology?
The pathology.
Teratoma, yeah. Malignant or not? Malignant or not?
It is
Final
under,
report has not come.
evaluation
This
only.
is only on verbal.
Thank you, sir.
Thank you for the wonderful discussion and participation from all of us. Thank you so much.
That was quite a thought-provoking session. I request Basant Kumar sir to present token of gratitude to Dr. Renu Sethi, Dr. Archana Kumar, Dr. Sushila Jaiswal, and Dr. Avinash D. Gautam. Avinash D. Gautam, please join us on the stage.
Is Dr. Avinash and my friend. He is just joined as the assistant professor here. Very dedicated.
As we are delving into the things, we are losing track of time. I request our respected speakers to keep an eye on the time limit, and our esteemed delegates, please, there's 5 minutes for discussion. So now I invite upon stage Dr. Saksham Singh, oncologist RML, and Dr. Divya Prakash, associate professor AIMS Raebareli, to chair this session and introduce our next speaker.
Yes, Samir Bakshi. There is finger is not here.
Can we call, excuse me, can we call Bhavna? Bhavna, madam?
Yes. Yeah, please call.
Dr. Samir Bakshi is unavailable right now, so I request our chairpersons to introduce our next guest.
Can we call, invite Bhavna, madam, who is a consultant neuropsychiatrist, associate professor from Bangalore. Name by John.
Good morning, everyone. Dr. Bhavna Prasad, consultant neuropsychiatrist and also a child psychiatrist from Bangalore. And before I start my session, I would like to thank Dr. Sushmita Madam and Dr. Basant Sir for giving me this opportunity. I consider this as my privilege. And why psychiatrist in this session? Why? What is the need for my session is mainly, you know that there is so much of load of cancer in India, and also a lot of pediatric surgical load is there. And parents and children go through a lot of stress. So as pediatric surgeons or pediatric surgical oncologists, how can you spend some time in your OPDs and your routine so that you can assess the level of anxiety in children who are above 4 or 5 years, and also in parents, and then refer them. And as it goes with today's theme, early detection and early referral. So that is the whole reason for this topic. How to change the slide? Amit. This is some of the statistics. According to WHO, approximately 3 lakh children between 0 to 14 years are diagnosed with cancer each year.
but they represent only 2% of all the cancers, even though the leading cause of children between age 1 to 14 years is cancer. And these are some of the common cancers. And also, because there are a lot of pediatric surgeons here, there are 2% of babies born with congenital defect every year. Among that, 0.1% requires an urgent surgical intervention. So this shows there is a huge load of pediatric surgeries. Now, when do you expect that these children or the parents undergo anxiety is, especially when it comes to the cancer related cases? It could be at the time of the diagnosis where you're going to tell them about the diagnosis, or anytime during the course of the treatment, or sometimes even after the recovery. So it is not that only in the beginning you should do the counseling. It is throughout the process till the recover, and sometimes even after the recovery, there is a lot of anxiety. And especially children with inadequate family support and poor temperament suffer more than what is expected. And here I would like to stress on 2 points. It is not just the case, or it is not just the few set of children or diagnosed who undergo anxiety. It mainly depends upon the person's personality, parents' personality. And in children, we don't use the word personality, we use the word temperament. So sometimes you come across parents who would show more anxiety, they might be asking more questions, or you might come across the children or adolescents who throw a lot of temper tantrums, not very cooperative for the procedures. So you need to understand it is not that the child is very arrogant or rude, it is because of the underlying anxiety. So also the same goes with the parents. And also there are certain families with poor coping skills that may suffer a lot. And when it comes to the statistics of how much percentage, around 75% of children and also the parents experience pre-operative anxiety. And when I mention anxiety, it is not just the worrisome they have, it is a clinically diagnosable anxiety and depression. And around 58% can have symptom of depression, 23% can have post-traumatic stress disorder. And also you need to understand that whenever they have parental anxiety, that even going to affect the child's anxiety. This is a particular study which tells about the amount of parents undergoing anxiety in the children with congenital diaphragmatic hernia. And there is an interesting finding is in this study where they show that even the gender difference can be seen. That means the anxiety is more among mother compared to father. And when you know, I mean, why do you even consider this counseling in these cases? Is there are a lot of factors which are contributing to anxiety in parents. One, like most of the factors are known to all of you, like parental separation, leaving a child 1 day or 2 day child just for 5 hours or 2 hours is a very difficult task for any of mother or the father. But now you take the child inside the OT or any procedures, so there is some amount of parental separation, lack of control over what is going to happen. You don't know the prognosis, you don't know how the surgery is going to happen. And definitely during your counseling sessions, also you explain parents about the complications. So that also can lead to, and parental gender, as I just mentioned, that mother show more anxiety compared to fathers, and fear of post-operative pain, age of the child. This is very interesting that as the age progresses, the parents expressing anxiety also increases. So you need to know that a parent coming with 1 day old child, if you compare a parent coming with 10-year-old or 15-year-old child, the anxiety is more with the parents who are having older children than 1 or 2 days. That is basically because of the less bonding they share with the child. And also fear of financial losses they are going to go through. And other family members might be at home, elderly parents are at home, or another child has to attend the school. There are a lot of factors which is going to get disturbed. And also post-operative pain and future of the child, like how much he is going to recover, whether he can attend the school, for how long he is going to be off from the school, and nowadays parents have a lot of dream. It's not just related to the academics, sometimes even the sports or any other activities. So they are concerned about the future and the child's disability. And definitely my husband was just showing me a picture of a child with a lot of scars on the abdomen. So definitely fear of cosmetic issues of the child. So these are all the factors which can lead. And before this, I also want to tell you that, as I mentioned in the beginning of my talk itself, not every child is same, not every parent is same, and not all the cases you can expect the same amount of anxiety. So it is the person's personality, parent's personality, or the child's temperament, which is ultimately going to define. You might think that, why is this patient annoying so much? Why is this parent not understanding? I have explained 100 times. No, it is because the person's anxiety. So what can you all do in your initial evaluation is, You need to assess the child's premorbid development, how was the temperament, and psychological history, functioning, and this all I think you all consider anyway do it, genetic disorder, significant life event if the child has undergone any kind of trauma, sexual abuse, and how is the educational attainment and academic strength. That gives you some idea of how is the cognitive ability of a child, how much the child can understand. The more intelligent, the more cognitive ability, the child is going to express more anxiety. And when it comes to parents, you need to assess their personality, their life events, and if a parent is already having any of the psychiatric disorders, then the challenge is more. And how is the family functioning, social support, which all contribute to number of anxiety. So now I am going to introduce few of the screening tools which can be used in your OPDs or their clinical setup, and quickly you can assess the level of anxiety. These are all with high validity and are easily available and can be converted into the local language also. So there is revised child anxiety and depression scale, pediatric symptom checklist, brief psychiatric rating scale for children, and impact of event scale. As such, only for specifically for preoperative anxiety, I could find only one scale. But let me again tell you that these scales can be applied only if the child is at least 3 years and above. Less than that, you cannot apply, you cannot assess the anxiety of a child. So I am going to share the PDF later of this scale, which I think you can use it. Pediatric symptom checklist. This will be filled by parent, not the child. And it is going to cover both physical and psychological well-being of the child. And now in the similar way, we have certain screening tools for parents as well. As I mentioned, during their waiting area, whenever they are sitting and waiting for the procedures, anytime you can ask your trained nurse or anyone to just give them these scales. This is one which I'm showing is hospital anxiety and depression care, which covers both anxiety and depression in the person. These are very simple questions which will be answered. And if in your OPD or in your department, if you come across any parent having score more than 10, that means that this person is not having just normal anxiety or worrisome about the surgery. That could be handled by you, but definitely this person should be referred to a mental health professionals. So now, once you know the factors causing anxiety, now you know why, how the personality and temperament plays a role in person's anxiety. Now you know. Now, what we do post-treatment evaluation is, for children, there are a lot of things like impact of physical sequelae if patient has lost any of his functioning, treatment received so far, educational engagement, how much he has been able to cope up, whether he has gone back to school, how much is functioning, and cognitive problems. Sometimes they can have poor attention because of the underlying anxiety and psychological symptoms. And for parents, you need to assess the family functioning, whether they've been able to cope up with their financial problems or any other issues. Parenting style. Post-operatively, you can see different type of parenting style. Some can become overprotective, over-anxious. Even though you have told the parent that a patient is absolutely doing well, child is fine, he can go back to school, he can do all the activities, but still parents are not sending. Or sometimes they can become too critical with the child, or sometimes if they are coming from a poor socioeconomic status or a father with more of a narcissistic personality, then they can start blaming the child. Because of you, I've lost so much of money. Because of you, I've lost my job. So these kind of critical comments can also happen. All these things will be assessed, and current social circumstances where they're living, and also again, as I told, psychological symptoms. Now you have assessed all these. Now you can consider a medical term for the anxiety, what they're going through. There is something called as pediatric medical traumatic stress, like how we call it as PTSD. This is the set of psychological and physiological response of the child or the family to any of the pain, injury, illness, medical procedures which they express. So more like they have all the anxiety symptoms, panic symptoms. And I am going to here highlight on few symptoms which you can yourself ask the parent. Very important, as we all know that biological functioning is very, very important. You can just ask the parent, how is your sleep and appetite? These two are very important biological functions when it comes to mental health. Anybody, if they say consistently for more than 2 weeks, they're having disturbed sleep or any kind of change in their appetite or decreased concentration. And also sometimes you can observe their behavior towards you. If they're becoming more irritable, getting angry, or asking too many questions, that itself give you a hint that this person is going through some psychological issue and he needs a help. And now another entity which we diagnose is adjustment disorder, where parents of children with cancer or any of the major surgeries may experience enormous physical and emotional pressure. Children and teens, definitely when they come to adolescent about 10 years, they are going to have all the cognitive abilities. So they also undergo a lot of adjustment. And now there is an important term here, illness cognition. So you might have diagnosed 3 kids with the same illness, same cancer, with same prognosis, but not all the 3 kids and the 3 parents are going to respond in the same way. What is that then differing is the illness cognition, means how much they have understood, and also not just understanding in the terms of understanding about the prognosis and all, but whether they are more positive about it or whether they are more negative about it. Some parents can have only negative cognition, where even after telling 10 times that the prognosis is good, they are going to believe that no, maybe I'm going to lose the child, maybe the child is going to die. Or sometimes you have explained everything and told that the prognosis is bad, then they might have a pseudo-cognition. So what is more important is what the parent or the child feel about the illness. And all of the any anxiety related disorders can be seen, which can manifest at any stage of the treatment. As I told you, it can be at the time of diagnosis, during the course of treatment, and sometimes many years even after the child has recovered. It is often intense at the beginning, but can at times be expressed as a refusal of treatment or procedures in the beginning. And there is a specific anxiety called procedural anxiety, which is for procedures. So it can be as simple as taking a blood test, pricking nails, or any kind of invasive procedures, or as such taking the kid for CT, MRI. Many a times we get a lot of calls that child is not cooperative for MRI, child is not just listening. So there is definitely, that is called procedural anxiety. So these are the common psychiatric illness reported in the parents of cancer or any major pediatric surgeries. As I mentioned, procedural anxiety, illness-related anxiety or illness anxiety disorder, where they have the specific anxiety related to, they might go through a lot of research. And if you are seeing a patient coming from upper socioeconomics, educated, they will a lot of Google search about the surgery, procedures, complications, everything. And whole day they'll be only thinking or talking about the illness. Panic disorder, where they get intense fear, can have all kind of somatic symptoms like palpitations, sweating, tremors, insomnia, nightmares or night terrors common in children. And sometimes you can see what is called as secondary nocturnal aneurysms. Primary means from the birth itself, child has never had a control over the bladder. But secondary means sometimes after a severe trauma or any major event, that in a child which had stopped doing the not having the aneurysms at time, now it has started again. So this can be seen. Generalized anxiety disorder, mixed anxiety and depression, major depressive and post-traumatic stress disorder. Now, what do we do as a psychiatrist, child psychiatrist or a general psychiatrist? How are we going to intervene whenever there is a... So we have non-pharmacological and pharmacological intervention. In majority of the cases, 80 to 90% of the cases, we are going to consider only non-pharmacological intervention, because already child might be receiving chemotherapy, might be going through a lot of other drugs. We don't want unnecessary medications or complications. And also this can be handled well with non-pharmacological. So parental counseling is what is considered here. The definition of counseling is there, but what you need to understand is parental counseling in continuum. So most of the time I've seen surgeons, pediatric surgeons doing counseling before the surgery. You definitely do it. You take a lot of time and explain them about the procedure, but that itself is not should not end there itself. It has to continue throughout the process, throughout how many times the patient comes for follow-up. Every time, make sure how much ever you are busy, you might be having a lot of surgeries next in a queue, but make sure that the child and the parent receive a proper counseling every time they make a visit. So preoperative anxiety intervention, there are which you consider it as preoperative education. And I am sure that most of you are all from the central institution, so definitely you all follow protocol. But I have seen in peripheries where they just do the counseling over the phone call. You come tomorrow with 6 hours of fasting and then you come and get admitted, we'll operate on you. So that kind of counseling should not happen. It should be a proper face-to-face counseling in a dedicated area where there is no much of noise, no much of disturbance. You can use paper-based methods, or you can use audio visual. As I mentioned, the children, if they are above 6 years, 7 years, you can show them animated video. Adolescents, you can explain them then what exactly you're going to do, what is the procedure, what is anesthesia, what are you going to do it. So take some time, and the parent might ask multiple questions, they might have multiple doubts. But if you want to get that complete trust of the parent throughout your journey, then this is where you need to hold them. The first few sessions, parental counseling sessions, which you do should be very well done. And these are the components which should be included. Accuracy, tell them exactly what your medical knowledge says. Then it should not be like beating around the bush. Be specific and tell them what exactly is it. Show some empathy, because I think as a pediatric surgeon, you all have that. So make the parent realize that you understand what they're feeling. Reproducibility and cohesive means if you have a team, you have a junior surgeon, you have a senior surgeon, you have an anesthetist, you have a surgeon, nurse. If you have a team, each and every person should give the same information. One has said the prognosis is good. Some other doctor will come and take the rounds, and they might say that I don't know, maybe. So be specific, and all of you should give them the same information. Suppose if there is a bereavement, if the baby has, there is a death of a child, something has gone wrong, then the whole bereavement team, which includes psychologists and social workers, should come. And the therapy, if suppose you have done a screening, you have assessed, and you have felt that the child or a parent is having more anxiety, so what exactly we as a psychiatrist do is, we include certain psychological therapies, and especially for child, we cannot do any cognitive related therapies. What we do is more of behavioral therapy. We teach them how to control their anxiety. To begin with, we make the child understand that it is okay what you're going through, because many a times they're not coming and expressing that I'm feeling anxious like others. They just throw tantrums. They are very irritable. They might be more demanding these days. So this is how we pick up that the child is having anxiety, and we take them for behavioral therapy. And for adolescent, definitely they are very good cognitive development is there. We can take them for therapies. Keeping thought diaries, we teach them. Guided imaginary, like, if you're taken for surgery, imagine that, you're not in a OT or somewhere else. Positive self-talk. I'm not going much because that is our job. This is again mindfulness-based therapy and progressive muscle relaxation therapies. And these are actually not a very difficult ones. Some of person in the department, if you don't have a proper psychiatry setup, a nurse can also teach these relaxation techniques. Play therapy. And in this play therapy, not just the child, even the parent is involved, and we teach them how to ease, how to go about the surgery. Music therapy is nowadays the latest development. And if I have to tell about the pharmacological treatment, as I mentioned in the beginning, we usually avoid till a child is showing a severe anxiety or the depression symptoms. Suppose there is especially the biological symptoms. There is very much deprivement of the sleep, or child is not at all eating, not sleeping, or showing severe panic attacks. Then we consider the safest drugs, which are selective serotonin reuptake inhibitors, SSRIs, like for example, escitalopram, fluoxetine, sertraline. These are some of the drugs which are very safe. And most of the time, SSRIs do not have any major drug interactions with any of the chemotherapy agents or any other drugs which you are using. And also when we give a minimum possible dose for minimum duration. Meanwhile, we also take up the child and the parent for therapies. So most of the time, we avoid pharmacotherapy for minimum period at minimum dose. And this I have already mentioned. So sometimes you can also use only benzodiazepines, like if the child is not having major anxiety or depression, but only comes up with panic attacks just before the surgery. Panic attack is showing anxiety symptoms just before the procedures. Then you can use, especially you can use short-acting benzodiazepines, because that will not have major later effect. And coming to, so now this is all overall what you can do at your setups and how we can go about. So taking simple measures like giving a very good preoperative counseling, taking time in explaining them, listening, assessing their personality, the temperament of the child, and simple tips like reduction in the number of OPD visits. If you call the child, they might have come from very far places, as many as procedures, what and all you can do, finish off in one visit. Extension of free of charge category, involvement of NGOs, which I'm sure most of the institutions have. Parents of patients suffering from complex congenital anomalies should be referred to a clinical psychologist. So this I've seen in many institutions where I was working in St. John's, where they regularly send the child to child guidance clinic for the preoperative counseling, and periodic counseling sessions should be conducted. So to conclude, as the today's this conference theme itself says, early detection and early referral. So what I would like to stress as a child psychiatrist here is, as a pediatric surgeons, you might be following the protocol of preoperative counseling, but also include certain screening tools and also involve the parents or other family members. And if at all any time during your process you come across anybody having more of anxiety and depression, kindly refer them, because how the controlling anxiety or depression is going to anyway affect the course of the illness is definitely, if a parent is having so much of anxiety, it is affecting the child's health also. So, and also sometimes the productivity, their financial income has come down because of their anxiety. So in overall development, you are going to help them, and that would ultimately indirectly affect the prognosis of the child also. So screening tools can be used. Referral to psychiatrists or psychologists should be done for early diagnosis and management. Child psychology should be included in the team. Adapting integrative preoperative preparation program can significantly reduce the parental anxiety. And periodic counseling and regular follow-up visits are to be done in case of children with any chronic illness. So this is how what I wanted to stress on, that there is a high prevalence, around 75% of anxiety and depression among parents and also the children, especially adolescents. And using simple screening tools, you can detect them at early stage and refer them for the further management. So I really thank Dr. Sushmita Madam and Dr. Basant sir for giving this opportunity. And with this, I conclude my session. Thank you.
Hello. Thank you, ma'am. So I have few questions. Sometimes they are very common questions and they are very common complaints by the patient. Any good evidence-based drug for stimulating appetite? मेरा बच्चा कुछ नहीं खाता है. It's very, very common. And it is मतलब like they just want some medicine. मेरा बच्चा कुछ नहीं खाता है. It's with chemotherapy, it's with radiotherapy and surgery. And I think there is psychiatric component involved. And any drug, if any
So
evidence
usually
we use,
don't, as I mentioned, we don't directly go for the drug stimulants, appetite stimulants or medications. You can actually look at the parenting style. Sometimes, what is happening is the mother is behind the child all the time. Khalo, 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 thoda khalo. So most of the time, just the behavioral management for the mother and the child also. Sometimes the mother is very particular about what the child has to eat, what time the child has to, just changing the routine and involving them for the therapy. And, and as I mentioned previously, it is the mother's anxiety. It is the mother anxiety which is making child also go through. So that would be enough, what I feel.
latestly, many doctors are prescribing syrup Activate. I think it has cyproheptadine. What is your take on that? Means should we use it? Means I know drugs should not be used, but sometimes
Sir,
they are
for
help
a
at.
period, if there's so much of significant decrease in appetite can be used. I would suggest that it can be used.
Another question, most of the higher centers, they are giving midazolam and ketamine for pain related to procedures. Now, do we have some syrups like melatonin is coming up, syrup melatonin is coming, like for blood tests, we cannot give midazolam and ketamine. So many times we don't have anesthesia team to, monitor the vitals while giving midazolam and ketamine. And in resource constrained hospitals, we cannot give midazolam ketamine that easily. So do we have some drugs like, what is your take on the drugs which are available other than midazolam and ketamine for helping with the sedation part?
Actually, as I told you, the short-acting benzodiazepines, like simple clonazepam, alprazolam, lorazepam, they don't have major side effects. The more you are worried about is CNS depressant action of the
Lorazepam is again injectable. Anything oral, Alprex we can give
yes,
to children.
alprazolam and clonazepam, they come in mouth dissolving form. So that, and also they have immediate action within 15-20 minutes the onset of action. So that can be given before the procedures and take the child.
Minimum age to start alprazolam and this clonazepam?
6 years.
6 years. Below 6 years is melatonin coming up? Syrup melatonin for the procedure, this to induce sleep or to induce sedation.
Risperidone, sir, very mild dose of risperidone because it comes in syrup. And risperidone is an antipsychotic, but here we are not using risperidone as an antipsychotic, but as a sedative. Like more like you use haloperidol for adult patients if they are dementia patient, if they are very aggressive and not coming for the surgery. In the same way, risperidone syrup comes. It comes in a with 0.1 ml, less than that. Like,
Okay.
you know, so that much 1 or 2 drops of risperidone can also be given because 1 ml is actually 1 mg. You don't need even 1 ml, 1 or 2 drops of risperidone, but that takes some time. Like you have to wait for 1 hour.
Okay, thank you, thank you.
Ma'am, do you recommend special clinics should be formed for, especially for the cancer patient for their counseling and all? Because at
Definitely.
times surgeons and we don't have that much of time to counsel them and give that much of support to them.
Yeah, definitely, ma'am. As I mentioned, also sometimes, you know, the counseling is a skill that we have been trained and we know how exactly to handle each kind of patients. So that's what I was recommending, that every oncology unit or a pediatric surgery unit can have one child guidance clinic. Need not be a psychiatrist, even a clinical psychologist is enough to handle them or counsel them in a proper way that is more advisable.
Audience, any questions? Thank you, ma'am. Thank you so much.
Thank you so much.
Thank you, ma'am, for stressing on the importance of mental health, mental well-being of a child in the management of children with malignancy. So the quiz has been postponed and the next time will be informed in the due course. So I request the chairperson to introduce our next speaker.
May I invite on the stage Dr. Sameer Bakshi, sir? He's head of the Department Medical Oncology AIMS. I'm privileged to invite him. I have been the resident when I used to review his papers, and I used to, in my journal clubs, I used to review his papers. He has taken my interviews. He has been my examiner also, and it's my privilege that I am chairing a session where sir is a speaker. And he's going to speak on role of immunotherapy in pediatric solid tumors.
Good morning, everybody. I'm a medical person and talking to a gathering of surgeons on a topic which is purely medical. I'll try and do something that I'm able to express it well enough that you are able to understand and enjoy the talk. The topic immunotherapy in pediatric tumors, the first line is that if I compare it with adults, the role is much less. The points that I will cover in the next 18 minutes or so will be the following: is cancer an inflammatory disease? The principles of immunotherapy and the targets, the prototype of immunotherapy in pediatric tumors, and is there a poor man's immunotherapy or not? So coming to the first question, is cancer an inflammatory disease? And let me start by saying that one of the models that may be thought of is a Barrett's esophagus, which results in inflammation, and then it goes on to develop into an esophageal adenocarcinoma. So inflammation going into cancer. Likewise, the role of H. pylori and gastric cancer and maltomas again tells you that there is inflammation that can go into cancer. Again, there is a risk of IBD and colorectal carcinoma. Again, the same principle. So just to recapitulate the hallmarks of cancer: sustained proliferative signal, evading growth suppressors, resisting cell death, replicative immortality, inducing angiogenesis, invasive, and metastasis. And to add on to these hallmarks, we have two other things: abnormal metabolic pathways and evasion of the immune system. And what enables all these hallmarks are two things: genome instability and inflammation, once again. So there is a lot of interest nowadays in tumor microenvironment. So the shift is that you actually, not just the cancer cell, you look at what is around the cancer cell. And the classic prototype of this principle is Hodgkin's lymphoma. In Hodgkin's lymphoma, when a pathologist sees a slide out of 100 cells that will be seen under the microscope, maybe 1 or 2 would be the cancer cell, and 95 or 98% of the cells are inflammatory cells. So if you look at this slide, there is only 1 or 2 cancer cells in the entire slide. The rest all are inflammatory cells. But it is still a tumor. It is still a tumor that can kill when 95% of the cells are inflammatory cells. So the tumor microenvironment can be classified as hot or cold. Hot meaning inflamed. That means there are a lot of infiltrating inflammatory T cells. And cold means that the inflammatory cells are excluded. That means it's an immune desert. I did a search 2 years back, inflammation, cancer, prognosis. I got more than 15,000 articles. I did this search yesterday, and the number of articles were touching 17,500. So that is the relationship of inflammation and cancer. Now, the TCGA has looked at the landscape of cancers, and they've looked at more than 10,000 tumor samples, and they have actually classified tumors as immune responsive and immune resistant. Let me tell you, colorectal cancer, you could have a same tumor with a high high MSI, which means that there is genome instability, and this particular colorectal cancer will respond well to immunotherapy versus that which does not have MSI. Now, you must have, I will introduce another term, tumor mutation burden. If the tumor mutation burden is high, the tumor will respond to immunotherapy. Now, this term will also tell you which tumors are high in mutation burden, environment related. So those who smoke, so lung cancer, classic example of a high tumor mutation burden. Those who chew gutka, tobacco, high tumor mutation burden in the oral cancer. But the pediatric tumors are not due to these influences. They happen de novo. And that's why they have a low tumor mutation burden. So going by that logic, if the tumor mutation burden is low, they will not be immune sensitive. I mean, they will not be sensitive to immunotherapy. So we looked at Ewing sarcoma at our institution. This was a study of more than 800 patients of Ewing sarcoma. And we found that those who have a high TLC end up doing poorly, both for event-free and overall survival. Now, on paper or technically, Ewing sarcoma is a tumor with a low tumor mutation burden, but yet there is impact of neutrophils, inflammation. So based on this, I conclude that inflammation is integral for several cancers and has an impact on treatment. Even tumors which are cold, which are seemingly not having inflammatory cells and not responsive to immunotherapy, I believe that there are targets which we have not identified, which we can target and have immunotherapy in the component of treatment. I will introduce this gentleman to a team of surgeons, and he's a surgeon himself. He was an orthopedic surgeon, William Cooley. In the late 1800s, he was working in the current Memorial Sloan Kettering. And as a lecturer working there, he found that the soft tissue tumors that he was seeing in his clinic, whenever they got infected, some of these tumors disappeared or reduced in size. He was intrigued by this finding. So he started working in the lab, and he is the pioneer of cancer immunotherapy. When he worked in the lab, he discovered a factor which later came to be known as tumor necrosis factor alpha. His name is William Cooley. 10 years back, there was an issue in Science, and the whole issue was just dedicated to cancer immunology and immunotherapy. You would have all encountered, if you do a genome sequence, everything about a tumor, you have a same tumor, same Wilms tumor, or same Ewing sarcoma, you have the whole panel of the genome. Yet two tumors do not behave exactly the same. That's the beauty or interest about medicine. And why would this difference be? We have the 3 E's: elimination, equilibrium, escape. That means there is always a fight between the tumor and the immune system. Whosoever wins, wins the race, wins the battle. That is why the same tumor does not behave the same way in every individual. So what do the tumors do? There are co-stimulatory pathways where the immune system will able to work to kill the tumor. And the tumor, if it has to stay in the body, it will have to down-regulate these pathways. What are immune checkpoints? Immune checkpoints mean that the tumor would up-regulate these pathways and create burden or problem for the immune system to kill the cancer cell. So these are immune checkpoints. And to counter these, we have developed immunotherapy approaches. The approach may be passive, like an anti-tumor antibody, or adaptive cell therapy. Adaptive cell therapy basically means that you use the cancer patient's own lymphocyte, expand it, and reinfuse into the patient with cancer. The classic example of that, which is being currently used, is CAR T-cell therapy in the management of ALL, myeloma, BNHL, and research is going on to expand this work to the use of solid tumors as well. What targets to choose? So let's say if we have to target a pediatric solid tumor, we want to choose a target that is there in the tumor, ideally, and not anywhere else. Because that way you can just target the tumor cell and not target anything else in the body, and so no side effect. So it has to be there on the cancer cell, not on any other cell. And even if it is there on some other cells in the body, it should be such that even the side effects are minimal. So neuroblastoma, which is the prototype for immunotherapy, the target is GD2. It is present in neuroblastoma, and it is a perfect target to target. And for that, we have an antibody, which is the denutuximab. And there are trials wherein denutuximab in a post-transplant setting has been combined with GM-CSF and interleukin-2 to augment the cell-mediated cytotoxicity of neuroblastoma cells. If you look at these Kaplan-Meier curves, the line above is the one with the denutuximab, and the line below is the one without denutuximab. Clearly, there is a 10 to 15% improvement in survival if you use immunotherapy versus if you do not. Next comes active immunotherapy. Active means you will enhance the T cell function. It's not passive. You are doing something wherein the innate system will start working more. So enhancement of T cell function, introducing vaccines, or you use checkpoint inhibitors. If you look at this interesting cartoon, what it shows is that the antigen presenting cell, this lock is there between B7 and CD28, and this will activate the killing of cells. In a tumor, what they do is they avoid connecting with CD28, and a new marker or a new molecule gets expressed on the T cells so that the antigen presenting cell cannot bind, and hence the cell kill cannot happen. What do humans do? Humans make an antibody against the molecule that has been made by the T cell, and this is called immunotherapy concept or checkpoint inhibitor concept. So this is an example where you have so much tumor of a melanoma, and after use of immunotherapy, it has disappeared. 15 years back, our group published an article saying that metastatic melanoma has an outcome of less than 10%. Today, when a patient comes to me with metastatic melanoma, the outcome of cure is more than 50%. More than 50% chance that a widespread metastatic melanoma can be cured with immunotherapy. So that is the impact of this treatment. Now comes the cost. If I have to use immunotherapy for 1 year as a checkpoint inhibitor, the cost in Indian rupees would be 3.5 to 4.5 million. And the immunotherapy for neuroblastoma, since it's not even being marketed currently and we have to import, it will come to almost 7 million for a body surface area 1, or maybe 3.5 million for half the body surface area. So that comes to almost 35-40 lakhs, which in general is not affordable for a fair number of people. Do we have a poor man's immunotherapy? That's the last question that I'm going to try and answer. A poor man's immunotherapy. And this answer comes from this instrument, which is a metronome, and those who play music will know this, that it gives a beat at regular intervals. And that is the concept of metronomic therapy. That means you give therapy at frequent intervals. You do not give a drug-free break, and it's at a lower dose. Nowadays, in metronomic chemotherapy, we also use non-anti-cancer drugs, and hence the term is metronomics. So what is the mechanism of action of this mode of therapy? It is believed to be anti-angiogenic and anti-inflammatory as well. Our center did a trial using a combination of thalidomide, celecoxib, cyclophosphamide, and etoposide as an anti-inflammatory regimen in refractory solid tumors. This was published in JAMA Oncology in 2017, and this showed that in non-bone sarcomas, the use of this metronomic therapy improves progression-free survival and overall survival. 3 years later, nowadays in high-risk rhabdomyosarcoma, we use a 1-year maintenance metronomic therapy as a standard therapy these days. In fact, oral metronomic therapy is equivalent to pazopanib in advance of tissue sarcomas as well, and that also we have been able to show from our data. So that was my last slide, the concept of a cheap man's immunotherapy if somebody cannot afford 35, 40, 50 lakhs of rupees. I want to thank the institute where I work, the All India Institute of Medical Sciences, and thank you all for a patient hearing. Thank you so much.
Thank you so much, sir, for your broad elaboration on the immunotherapy and metronomic therapy, especially because most of the times. Hello. So many times we get across with these elaborative diseases and patients where the disease has crossed the curative intent and it has reached the palliative intent, and we end up giving them metronomic therapy. And yes, it is really the need of the hour. Thank you, sir. Any question from the audience?
Dr. Bokshi.
So specifically, if I have to say of anti-VEGF, that would be two kinds of therapies that we can use. We have the oral tyrosine kinase inhibitors, and the second is bevacizumab, which actually targets the VEGF. The bevacizumab is a very toxic drug to use, expensive and toxic. In my opinion, that's an expensive placebo, expensive toxic placebo. That's how I sometimes think about it. And bevacizumab has been tried from head to toe in all tumors. In no tumor, it has resulted in an improvement in overall survival. And it has severe toxicity that can cause intestinal perforation. And in a palliative setting, that can become a real problem. In terms of TKIs, we have tried in several tumors, and we do use it. In pediatric tumors, one of the prototypes is desmoid tumors. It works very well there. In fact, it is the drug of choice. Sorafenib is the drug of choice in fibromatosis. The oral metronomic therapy also works as an anti-angiogenic treatment. So that is another form of anti-angiogenic therapy. Coming specifically your question to Wilms tumor, that has increased expression of cyclooxygenase, and the therapy that we used included celecoxib, which again targets cyclooxygenase. So I hope I've answered your question that these are the various options that can be tried. Thank you, sir.
Thank you, sir.
Thank you, sir, for enlightening us about the immunotherapy in pediatric solid tumors. I would like to call upon Dr. Basant, sir, to present a token of our gratitude to chairpersons and speakers, Dr. Samir Bakshi, sir, and Dr. Bhavna Prasad, madam, and the chairpersons, Dr. Divya and Dr. Sakshan. Now we'll move on to the next session, which is the debate section. I request the chairperson, Dr. Sandeep Agarwala, sir, HOD and Professor at AIIMS, New Delhi, and Dr. Pinaki Devnath, sir, HOD and Professor, RML Hospital, New Delhi, to join us and announce the topics and the debaters. The topic of debate is, should genetic testing be mandatory to pediatric cancer patients? And those debating for are Dr. Prabodh Goyal, sir, Additional Professor, AIIMS, New Delhi, Dr. Manish Pathak, sir, Additional Professor at AIIMS, Jodhpur. And those debating against are Dr. Monica Bhagat, madam, Senior Consultant, Mumbai, and Dr. Arihan Jain, sir, Assistant Professor at Dan Medical College.
genetic testing.
We'll start with our debate session. We'll start with Dr. Prabhu Goel, sir.
So, can we ask the organizers, so what format have you planned for this? There was some planning going on in the WhatsApp group. Both the four will speak first and then against, or?
Yes, sir. Both the
How
four.
do you plan?
So I will speak and Dr. Manish Pathak will speak.
Okay.
Then the against.
First. How much time have you kept?
We thought it's like the total session is 5 minutes each.
5 minutes each,
5 to
okay.
10 minutes each.
And then counter? After that, have you planned for counters after the end of the two talks?
So, sir, it depends on the chairperson. If
Okay.
you feel there's a need for counter, then.
Okay, so we will start with this debate on should genetic testing be mandatory for pediatric cancer patients for the people talking are Dr. Prabodh first and then Dr. Manish Pathak.
Respected chairpersons and my dear colleagues, very good afternoon to all of you and greetings from the debate team. I am thankful to Dr. Basant and his team to give me an opportunity to debate on this topic on this platform. We are discussing if genetic testing should be done for all pediatric cancer patients, and I shall be speaking for the topic. So we all understand that genetic testing is a whole new world of insights. These two words, genetic and testing, seem very small, but when you go into the intricacies, it is a mega subject. So here I am trying to depict the vastness of the role of genetic testing. When I was preparing this topic, I was reminded of my MBBS days. I did my MBBS from King George's Medical University itself. So that was the time when my parents used to give me some 2,000 rupees per month for all my expenses. And Harrison used to cost around 16,000. So we went to a local market behind Hazratganj and I could find a local copy of the book. Now, the challenge was, once I got the book, if it has the same content as the original Harrison. So here we have the gold standard, which is the reference human genome, and we have the patient who has the disease, and we are trying to identify his genetic composition. And through this analogy, I will just go through the basics of genetic testing to help you understand what all is possible. Because unless we know what all is possible, we don't know why it is important. So while I was comparing these two books, I realized that this local copy had two sets of all the pages. So technically it was double the Harrison and everything was in duplicate. So this is aneuploidy, basically triploidy, tetraploidy, and you can detect with the help of chromosomal analysis or karyotyping. The second scenario, the entire book was fine, but there was a chapter which was there in duplicate in the local copy. So this is analogous to extra copies of the chromosome, and this again is possible with karyotyping. Now I realize, no, it's not a problem with chapter also. It is a paragraph in the local copy, which is different from the actual book. So this is analogous to large deletions and duplications, and you can identify them with chromosomal microarray analysis. If just a line is different, that is analogous to small deletion or duplication, and you can find out with a copy number variant analysis. So these are the different types of genetic tests available. Now, there's not a problem with the line also. There's a single word, say Goel. It's instead of G-O-E-L, it is in G-O-O-L. So there is a single alphabet has been replaced, and this is a single nucleotide polymorphism, and you can identify with the help of next generation sequencing, which is whole exome sequencing or whole genome sequencing. Now I have to appear for a terminal examination and I realize I don't need to compare the whole book. I am concerned with a particular chapter which is included in the syllabus. So this is a disease panel which can be identified with the help of targeted sequencing. Now, my roommate, he was like, yeah, this book is comparable, but somehow I don't like the page quality, the typesetting, or the binding of the local copy. So this can be compared to DNA methylation or histone modification. Technically, that is the epigenetic study. And finally, after I read the local books, my teachers were concerned that this guy did not read original Harrison. Now, will this local book bring about the same change in his personality, his knowledge database, his attitude, etc.? So this is about gene expression or transcriptomics. So with this background, so what are the indications of genetic testing? So it's a very wide domain. Like I said in the beginning, we need genetics for clinical indications. We need genetic testing for research purposes. We need it for public health. We need it for ethical, legal, and forensic concerns. And finally, cross-population studies. So cross-population can be dealt with separately or as public health. We will focus ourselves largely on the indications related to pediatric cancer. The first one is clinical, which is the widest domain. So my colleague, Dr. Manish Pathak, would be talking in detail about this. But just to give an overview, you can use genetic testing in pediatric cancers to make a diagnosis of the disease. You can use it to identify the subtype of the disease. You can use it for risk stratification. You can use it to identify which would be the best or better therapy for the disease. You can have therapeutic targets identified and so on and so forth. So I leave this part to Dr. Manish Pathak. Then you can use it for research purposes like genetic discovery, clinical trials, tumor heterogeneity. We'll talk about it subsequently. Public health as in population screening programs. So to cut short, I just summarized all these into these points. And what are these are 7 indications I mentioned and just a brief about all these points. So basically what is happening is India is a vast country. It is geographically vast. We have peoples of different ancestries. So it is ethnically vast. The climate, the environment is different. So overall, you cannot club India into a single term when you're talking about this. So one thing is one size fits all. This does not apply to India. A research which has come from the Western world will not be applicable to us in an as-is manner. Secondly, we have realized, we all will agree with that, in most of the Western studies, our genetics is largely underrepresented or not represented at all. And finally, being such a huge economy, being an economy with such a huge population which stands out in the world, we should have a genetic database of our own markers. So our genetic database and the consequent genetic testing, it must reflect the unique needs and diversity of Indian population. Somebody may claim that my ancestry is common, but over the generations, things change. That's what we'll discuss. So this diagram is trying to represent India as a whole, but then you see that there are people from different parts of the country with different ethnicities, and they have different databases. So what has happened is that genetic markers from the Western world, they are not able to encompass comprehensively the diversity that we encounter in our population. And for those people, maybe somebody is coming has a common ancestry, had settled down 5 generations ahead. He has undergone what we technically call as genetic distancing. So his genetics may not work the same way what it used to work 5 generations earlier. So yet another creation wherein I am trying to depict the role of environment and epigenetics. So basically diversity within unity. So what happens is the same genetic markers in the genome of 2 individuals, they may behave differently when their effect or the outcome is modified because of the local environment or the epigenetic influences. Besides this environment or geography or epigenetics, we have also realized that the role of socio-economic factors also is again very, very important. So I'm sure none of us would disagree that India needs a genetic database which would become culturally relevant and which is culturally relevant to our society and which would lead to capacity building. And that is the way. So other than clinical part, I have emphasized on the other aspects why we actually need genetics. We need genetic testing in our patients of cancer. I have illustrated the role of genetics briefly with the help of one tumor, that is hepatoblastoma. We could have chosen Wilms tumor. I think Dr. Manish is talking about Wilms tumor. I chose hepatoblastoma because this particular tumor encompasses different genetic tests into one. So we all identify these two syndromes, and we know that hepatoblastoma is one of the manifestations in both of these syndromes. We know that the genetic basis of the etiopathogenesis of hepatoblastoma, it lies in the WNT beta-catenin pathway and partly into the canonical beta-catenin pathway. So we have seen the role of DNA methylation in hepatoblastoma, that is epigenetics. We know the role of tumor suppressor gene promoters like APC. We know the role of hypomethylation of so-called oncogenes leading to their activation. The other aspect of epigenetics is histone modification like H3K9 deacetylation and inhibition of SDAC. Both of these have again been implicated. So this was about epigenetics. We know the role of non-coding RNAs in hepatoblastoma, and these are the RNAs which have been described. So this was the clinical part, the research part, the community medicine or the population studies part. And I think a combination, a balance between all these aptly says that we do need to perform genetic testing in our patients with cancer. Dr. Manish Pathak, can you please continue from here? So thank you, Dr. Prabodh. At the outset, I would like to thank the organizing committee, Professor Sushmita Bhatnagar, Professor Vasant Kumar, for giving me this opportunity. So Dr. Prabodh has made the things very clear that how exactly do we do the genetic analysis and what are the factors, what are the various roles. So I will be focusing on the clinical aspects of it. So this is a famous pediatric radiation oncologist, Professor Giulio D'Angio, and he said that the oncology should be seen through the prism of Wilms. Now let us try to discuss this particular topic through the prism of Wilms. We all know that Wilms tumor, we are able to achieve the more than 90% 5-year overall survival. And this was possible because of the multiple cooperative group studies and ultimately the risk stratification of these tumors, incorporation of age, staging, histopathology into the risk stratification and leading to the more than 95% 5-year overall survival. But still, there are certain problems. We still, the outcome is suboptimal in anaplastic Wilms tumor, bilateral Wilms tumor, and in recurrent Wilms tumor. Now, and there are problems related to the chemotherapy-related toxicity. So, to overcome all these issues, the COG recently has incorporated molecular markers also within the risk stratification, and COG includes now the loss of heterozygosity at 1p and 16q, within the risk stratification to identify those favorable histology Wilms tumor where we need intensification of chemotherapy. So now we know that even in Wilms tumor, this risk stratification includes molecular markers. Now, what exactly are we trying to look when we are looking for the genetic changes or molecular alterations? These are either the mutations or the numerical or segmental chromosomal aberrations, the loss of heterozygosity, fusion translocation genes, gene amplifications. So these are the various changes we identify within the tumor cells, and based upon that, we decide whether these can be used for the diagnosis or other things. So now molecular alterations can be somatic alterations or germline alterations. Now somatic alterations are those which are present within the tumor cell. So when we do the tumor biopsy, then these somatic alterations are identified. And because they are present in tumor cells, these can be used to diagnose for the diagnosis, prognosis, and the targeted therapy. Now, while the germ cell alterations are present in all the cells of the body, so this can be utilized to identify those patients where the genetic predisposition syndromes are there. So the germline alterations, if they are present, then they will be useful for diagnosis, prognosis, and all targeted therapy, but will also be useful to diagnose the genetic predisposition syndromes and for screening purposes. Because sometimes the parents come to us, my child had cancer. Now, whether the other child is also going to have the cancer, what are the other family members, whether they are also at risk. So if the germline alterations are there, then, and it has got a high penetrance and expressivity, then there is high likelihood that other family members may also develop these cancers, and these family members should also be screened. So this is the importance of germline alterations. When we talk about the role of genetic markers, the clinical aspects may be in the diagnosis of the tumor. So there are certain specific genetic changes. If we identify those, then we may be able to identify that particular tumor type. So like SMARC B1, if it is identified, that it can help us in diagnosing congenital mesoblasthic nephroma, rhabdoid tumor of kidney, PAX-FOXO1 fusion genes, they are seen in rhabdomyosarcomas. So this can be helped in diagnosis. Similarly, prognostication. We know means neuroblastoma. Means neuroblastoma has got various courses. It can spontaneously regress. It can have a benign course. It may have an aggressive course at the time of presentation only. There may be metastasis and all. So this all thing, if we have to talk about the single most important factor that is determining the prognosis, is probably the anemic amplification. So this again also can be detected through the genetic analysis only. Then risk stratification means in various tumors, it has been incorporated in the risk stratification. I already talked about the Wilms tumor. In the neuroblastoma also, anemic amplification, if it is there, it becomes a high risk irrespective of age, stage, histology, and all. So again, it is important for prognosticating the patient's risk stratification. Detection of early response to therapy. Now, this is a liquid biopsy. Means if I will talk about the liquid biopsy in detail after in 1 or 2 slides. Then targeted therapy means Professor Samir Bakshi has already talked about it regarding the role of immunotherapy and how can we target it. Now, targeted therapy, if we are able to, take out this aspect of the genetic changes and then use it in targeted therapy, the chemotherapy-related toxicity also can be decreased. Then precision medicine. Now, precision medicine is the individualized treatment. And we cannot think of precision medicine unless we talk about the genetic changes within the tumor. So the precision medicine is almost all is dependent upon the genetic markers, the genetic testing and all. And then the parental counseling means to tell the parents that whether the other family members are also at risk or not, and whether the other child is also has a possibility of having this particular tumor, and genetic predisposition syndrome. So these all are the wide, aspects which can be utilized. Now, if we talk about specifically the individual tumors, the neuroblastoma risk stratification, I already talked about. Now, anemic amplification, but there are other aspects also like DNA copy number. Now, hyperdiploid tumor in infant, if it is there, it has got a favorable prognostic marker.
Similarly, the segmental chromosomal aberrations like 11q loss, that also makes it an unfavorable prognostic marker. And now targeted therapies, ALK inhibitors. Now, ALK is considered to be a prognostic marker and it is a potential target. So ALK inhibitors like crizotinib is being investigated in neuroblastoma also. Wilms tumor, we already talked about the loss of heterozygosity at 1p and 16q. Then there is an 11p methylation. There are, the group of Wilms tumor patients, we all know about the chemotherapy-related toxicity. How can we reduce the toxicity? Then these multiple cooperative group trials, they try to identify those patient groups who can be treated only by surgery. Now, for that, the certain criteria was defined. One was the age should be less than 2 years, the tumor weight should be less than 550 grams, histology should be favorable histology. And even after taking all these into consideration, it was found that some of these patients were still having recurrence. Now, what is that factor that is leading to this recurrence? So then this 11p methylation came and it is being investigated extensively and maybe incorporated within the COG trials also to identify those patients where we can treat them only by surgery without giving chemotherapy and radiotherapy. Now, targeted therapy, again, the anti-CD56 antibodies are being investigated and the CAR cell therapy. Rhabdomyosarcoma. Now, rhabdomyosarcoma, when we talk and classify these patients and stage these patients, the age and the site and histology, these are considered to be the two most important factors. Now, favorable site, whether it is favorable site or unfavorable site, whether the histology is alveolar histology or embryonal histology. Now, then came this changes, the fusion genes PAX and FOXO1 fusion. So it was seen that the embryonal carcinoma, histology embryonal rhabdomyosarcoma, who are having, suppose, PAX FOXO1 fusion gene positive. Now, that will behave like an alveolar rhabdomyosarcoma. So the more important aspects of histology, instead of histology, it is these genetic markers which either they are present or not. So nowadays we classify whether they are fusion positive or negative. And if the embryonal rhabdomyosarcoma is fusion positive, it is treated in the same lines of alveolar rhabdomyosarcoma and considered to be a poor prognostic factor. And similarly, now drugs are being studied where we can decrease the expression of PAX FOXO1 gene and for the maintenance of relapsed rhabdomyosarcoma, the mTOR inhibitors like temsirolimus is also being investigated. Now, germ cell tumors. Now, so there are certain germ cell tumors where we need to do the karyotyping because they are associated with certain the genetic conditions like the mediastinal tumor in boys, they are associated with Klinefelter syndrome. Now, gonadoblastoma, again, karyotyping is needed. It may be associated with Turner syndrome, Swyer syndrome, gonadal dysgenesis. So these are the conditions where if these tumors are present, the karyotyping should be done in these patients. Similarly, it can be used as a diagnostic marker in Sertoli acute cell tumor. Dicer1 genetic marker is there. Now, Dicer1 is also utilized for pleuropulmonary blastoma. Now, sometimes there is, a neonate antenatal diagnosis of a congenital cystic lung malformation is there. We do not know whether it is a pleuropulmonary blastoma or it is a CPAM. Now, if a Dicer1 mutation is, looked for, then we can label it as pleuropulmonary blastoma and can treat them more aggressively or doing the early surgical resection. Liquid biopsy. Now, at present, to diagnose these tumors, what we do is the tumor biopsy. A tumor biopsy has got its own issues. Now, there may be certain tumors which are present in inaccessible areas, or the tumor heterogeneity is there. We are hitting those areas which are having necrosis or they are not representative of the sample. Now, this problem is sorted out by doing a liquid biopsy. What we do is that, we know that these tumors are secreting the cells and they can be isolated by isolating the circulating tumor cells or cell-free DNA or cell-free RNA. And then we can differentiate whether it is a tumor cell or a normal cell based upon the particular markers that are present in these tumors and tumor-specific mutations. So if a tumor-specific mutation is there, we know that it is a tumor cell, it is not a normal cell. Then, it can be diagnosed. Then another aspect is you have diagnosed the tumor, started the treatment. Now you want to look for the early response. Now, doing a repeated biopsy of the tumor may not be feasible. So, tumor liquid biopsy, just take a sample from the blood or synovial fluid, CSF fluid, depending upon where exactly the tumor is situated. And then, trying to determine whether those levels which were there previously, it has come down or not. And based upon that, we can sequentially do the surveillance of these tumor. It can be used in follow-up and detection of recurrence, etc. So it has got significant role. Now, this is a study which was conducted by Dr. Saray et al. Had done this study, and they tried to identify the role of genome sequencing in pediatric solid tumors. So when they did this study in about 367 patients, and what they found was that this genomic sequencing, it led to therapeutic impact in about 50% of the patients. What do we mean by therapeutic impact? That if we because of this next generation sequencing, we were able to either escalate the therapy, de-escalate the therapy, or it was used in risk stratification. And also we identify certain markers which are seen in germline alterations also. And if these are seen, then these patients were investigated or other family screening was also done to look for whether other parents, other kids or other family members were also affected by this tumor. So it got a significant impact in those patients wherever this next generation sequencing was used to, in those pediatric solid tumors. So to conclude, we can say that it has got a significant role in diagnosing, prognostication, and risk stratification, and it should become a standard of care for pediatric solid tumors. Thank you.
May I invite Dr. Monica for against the motion speak to counter? Dr. Monica. Okay.
First?
Yes.
Yes, okay, Dr. Aryan.
Dr. Aryan, please continue.
Good afternoon, everyone. I would like to take this opportunity to thank APSO, Dr. Sushmita Bhatnagar ma'am and Basant sir for giving me an opportunity to participate in this debate. The speakers which have spoken for has really motivated me to go into the depths of research and reading, to do my best to come up with very good genetic testing modalities at very cheap rate, to make it available, to create equity of access for everyone. But what is more important is we need not to do everything. What we can do is best, but what we have to do is what is needed. So it is obviously very important for prognostication. It should be done. It is required, but it should not be made mandatory in every children with cancer. So it should not be mandatory. So why genetic testing is necessary? It is already being discussed and being told in detail by the four speakers. But where are we today at this point of time with genetic testing? As per this paper, in an international consensus or minimally preclinical testing requirements, whatever the anti-cancer drugs, the therapeutic part after doing genetic testing have been made available are based upon the drugs which have adult indications. So in which they have not given importance to the microbiological or biological relevance to the childhood cancer. And as Sir Samir Bakshi sir has told, that there is a tumor microenvironment, which is also very, very important thing to be taken into consideration while deciding whether the drug which is being used or the target which is being taken into consideration in adults has equal response, will have equal response to be used, suitable to be used in children. I will give examples in coming slides. So in children and adults, even if the mutation is same, but the genomic variations, structural variations are quite different. So the studies which have been quoted are basically based as adult based. We have to start first the research work, then we have to make it mandatory to be used in clinical settings. So new therapeutic, whatever the drugs like ALK inhibitors, crizotinib, these drugs lack dosage guidelines for children. So an act was passed by FDA that whatever the drugs, 63 drugs were available to be used, which have same mechanism of action and can be used in children with cancer, which we have identified the genes for. Out of those, only 3 drugs in detail they have given the regulations can be used in children. So when we don't have any treatment to offer to those children, why to subject every child with tumor or cancer to genetic testing? So as per this slide, we can see that in neuroblastomas, as four speakers have spoken, that ALK mutation, we can use targeted therapies like crizotinib and lorlatinib, but still this slide highlights that all maximum of the drugs which can be used are under clinical trials. So first, till the phase 4 trials are finished for all of these drugs, and we have the data in hand that we can offer something to these patients, then only we should subject these children to genetic testing. There is no point in peeping into everyone's genetics and opening a Pandora box to come up with the information for which we need not know what to do in the future. So available therapies like, just to review, for neuroblastomas, as we can say that ALK inhibitors, crizotinib is available. It has been shown in papers to have variable efficacies. It is having no adequate response being seen in any of the paper if being used as monotherapy. So if we have to use it along with other chemotherapy drugs, we have to do research first and then make the tests mandatory. And one drug like Sir has told that already we have clinical trials moved ahead is anti-GD2 monoclonal antibodies. Like immune checkpoint mediators we can use, but all those drugs are under surveillance. The CAR T therapy, which four speakers have spoken, is also under trial in neuroblastomas and Wilms tumor. So while seeing everything research going on all around the world and running behind the genetic testing, we should not miss the point of making the life and survival or better for these children. Outcome should improve by those things. So when we do genetic testing and we subject a child to next generation sequencing, do we have an expertise to integrate and read all the results? Reading the results of genetic tests is very complicated. Being a surgeon, to read this much what I have read has taken a lot of time, but to just read a single genetic report of the next generation sequencing is very difficult. Even if they have done this and have integrated with histopathologists, more than 80% of the children do not participate in those trials or cannot take those therapies because of poor performance status, because of already having been improvement in the course of the treatment, and they lack insurance facilities to take those drugs. When the cost of those drugs and treatments and even the genetic testing starts from 35,000, 20,000 and going up to lakhs and lakhs of rupees, when they barely could manage the completion of the treatment from starting of investigations in tumor board, we have seen that we were using investigations every 3 months, 6 months, but it is possible to do based upon the public, but it is costly. We can feel that might be patient is not paying, but someone is paying for all those investigations. So are we ready to just do genetic testing in all the children with cancer? Absolutely not. This is a very beautiful article being published in Lancet in year 2023, which gives sort of an assessment of childhood cancer services in India. What are the gaps and challenges? So we have to first meet the basic challenges before just straight away, based upon the research going in West, to just peep into the genetic testing for all. This study included 137 tertiary care hospitals, 92 secondary level hospitals across 26 states and 4 union territories. 80% of the children they have found in comparison to other countries are residing in the low and middle income countries with no specific program or policies available for childhood cancers. So this table I wanted to highlight this, that the basic facilities like availability of pediatric oncologists in a public hospital is in 48% of the hospitals. So it is, and pediatric oncosurgeon availability is just in 14% of the hospitals. So genetic testing can help, but we should first meet with the basic minimum requirement being available. The availability of the childhood cancer treating drugs, this graph specifically shows that in public hospitals, the availability of the drug in stock is less than 50% in all the public hospitals. And especially the targeted therapies, the availability is 30 to 35% of the hospitals. So when the availability of basic drugs, like which we give for Wilms tumor, neuroblastomas, is very less, so making it available making available the genetic testing to everyone is not a wise thing to believe in. This shows that the cancer treating medicines are free of cost availability is only in 30 to 40% of the public hospitals in India. So basic drugs like cyclophosphamide, doxorubicin, cytarabine, whatever these drugs are available, this pink color shows that the stock is that this is in stock, rest green is that not available. So we can say that basic drugs are also not available in many public hospitals in India. The facilities to give to provide the immunotherapy, chemotherapies, mixing room with vents, biosafety cabinets for making those drugs, radiotherapy setups is available in less than 70% of the public and NGO charitable hospitals across India. So less than 10% of the tertiary hospitals had provision for training courses in pediatric oncology and pediatric surgical oncology. Availability of pediatric oncologists as compared to West, which they have been doing in quite a bit research, is like in Ukraine is highest, is 1:4, compared to that in low and middle income countries is 1:750. The mortality ratio to incidence ratio for childhood cancer ranges from 17 to 72% in India. So this range is a bit of worry. This range shows that there is non-equity of access, non-equity of services being provided across India. In metropolitan cities, the availability of services may be good. We can afford some patients, most of the patients can afford to subject their children to genetic testing and all those things, but basic in peripheries where they have to come to metropolitan cities to access the basic treatment of surgery, chemotherapy, it is quite a bit for those parents and children. So to get good outcome in pediatric cancer, we should shift our focus from survival to thriving first, and then proceed further. The focus should be currently on dedicated pediatric oncology and oncosurgery units with supportive and hospice care. Availability of drugs should be made, and there should be national childhood cancer policies being made to provide better services to children. So this beautiful paper shows that the treatment abandonment rate in India is 10% to 60%. This is also a range. So the range is always a worry for me. So this shows that when a parent comes to us with a child having a mass in the abdomen, supposedly Wilms tumor, to convince them that this is the course of the treatment, this will be the prognosis, this is the treatment requirement, what we want from you to do. We cannot just explain them because the treatment abandonment rate is quite large in India. So we have to work on counseling part as such. Just doing research in genetic testing, making it available. But do we understand? We can understand by reading 1,000 times even the genetic testing and the significance of that. But do the parents understand? I don't think so that a parent coming to us in our hospital, it takes a lot of time to even explain to them the surgical procedure being required for perforation. They ask multiple questions. Why is anything like you can get away with doing just medicine part, no need of surgery? So we need genetic counseling in India. The part of the importance of genetic counseling is like genetic counselor is like an air conditioner in this room. when in earlier times we have open windows and all those things, we can feel that we might not need them. But when we have them on board in a tumor board, we have genetic counselors, we will be not be able to live without them. We cannot be able to run if the genetic testing, we have to move forward with genetic testing. So in India, we have the trained genetic counselors per million population is at the bottom. So we have to work on that part first before making genetic testing mandatory. So every patient remembers that how I felt, but he or she might not remember the gene. It is the experience the family perceives during the treatment, which makes them not to have lost to follow up. It is that important. The counseling part is that important. So quality of, and before doing genetic testing, we should focus more on like Beckwith-Weidman syndrome, which was the example being given by the four speakers. 70% of the patients with children with Beckwith-Weidman syndrome will have macroglosia, these hypertrophic syndromes like lateralized hypertrophy syndromes. We have to focus on those things rather than spending everything on tools. We should work on skills to pick those patients first and then do genetic testing to guide them what the prognosis, not by picking an hepatoblastoma and doing genetic testing to find out whether the child has Beckwith-Weidman syndrome or not. Because the risk of child with Beckwith-Weidman syndrome to have hepatoblastoma is less than 5%. It is higher, but the percentage of the patients with hepatoblastoma having Beckwith-Weidman syndrome is less than 5%. And the quality of history taking is, this paper clearly shows that the family history taken by genetic counselor is quite significantly better than compared to surgeons and oncologists. So the next concept which comes is of the consent. Before doing any genetic test, any surgery, we need to take consent, which should be clear, coherent, and the willing part is very important. It should be ongoing. With the literacy rate of less than 70%, that is also the census of 2011. When we don't expect our patients' parents to just understand the criticality of follow-up every 3 months after the surgery, after the completion of the treatment, how can we believe that they will be able to understand the wide criticality of genetic counseling, the genetic testing which they will be subjecting their child to? So pre and post testing counseling is very important. And for these things, we need genetic counselors as a part of the tumor board. So ethical, legal, and there are other issues like genetic testing, ethical, legal, and psychological issues. With by subjecting in the minor patients, it is the parents who give the consent. But by taking that part of the consent, the child is losing his autonomy, and the cost is quite high. And equity of access, as I told, is not everywhere. So we have to make it available. Plus, when we do a genetic testing, supposedly a child is subjected to a genetic test, like if he feels, we have to tell that the risk that supposedly RET proto-oncogene mutation, the risk of MEN2 is quite high. We have to tell the family members of that child to be in follow-up. But if the child doesn't want if the parent doesn't want every family member to know about this thing, because this can create.
Is Dr. Monica going to speak?
Yes.
Okay. Okay. Because you're doing already 15 minutes.
Just 2 slides.
Okay.
And with all those ethical and legal concerns, this will create social discrimination, stigma, like the child will be estranged from the family, might not be given equal educational or other occupational facilities being given to the other children in the family. So we should work on tools. This paper clearly shows that there are cancer predisposition syndromes being available. We have to first see the clinical symptoms, work on our skills, and if there is an indication to do the genetic testing in those children only, we should subject the child to genetic testing. Like there is a criteria named as Jongman's criteria, which have certain, like in Wilms tumor, if the tumor is bilateral, if it is quite early in the age group, and if there is bilateral nephrogenic rests on MRI, if there is multicentric tumor, then we can think of doing genetic testing in this useful in Wilms tumor, not in everyone. This is the childhood cancer indication for referral when we should refer a child to geneticists. They have mainly been focused on the clinical features. These are the patient characteristics which are suggestive of hereditary pediatric cancers. So if these characteristics are seen in the patients, then only we should subject the child to genetic cancer. So it should be done if malignant disease can develop in childhood, not when we expect the child will develop the malignancy in adulthood. As per American Society of Human Genetic Guidelines, we should defer this practice, and evidence of risk reduction should exist, which exists in few of the oncogenic mutation, knowing like retinoblastomas, a red proto-oncogene mutation for MEN2 and MEN2B, and APC for familial adenomatous polyposis. This is just to quote examples. And we should work in the child's best interest. We should try for most good and least harm comes to all. So this is the concluding. Thank you.
Thank you, Dr. Thank you. So, Dr. Monica. Fine. 18 minutes again. So, as a team, you have 5 minutes left.
Sir, good afternoon, everyone. Thank you, Dr. Basan, for inviting me. Sir, I had one doubt. Are we talking about somatic mutations or germline mutations? Because the topic says that we have to.
Topic is genetic testing mandatory for pediatric cancers.
So, I think Dr. Arinath has already spoken about the tumor biology, and others have also talked about the tumor biology. I had mainly spoken about the genetic germline mutations where
So you can talk against the motion. You have 5 minutes.
So I think this already has been covered by Dr. Arinath. So for in the pediatric cancer, if we have signs, clinical signs of genetic mutation, like a Beckwith-Wiedemann syndrome, or we can see that the germline mutations can be present, then we definitely need to do all germline genetic testing for the child. Otherwise, we can skip it. So I will skip all these genetic conditions. The problem is when you have a genetic condition and it comes as positive, the child has to undergo all the follow-ups for a retinoblastoma, frequent fundoscopic examination. Then every 2 months, basically there's a flow chart which is already present and existing to follow up these patients. So it helps us to detect the early cancer, and we can avoid radiation or cytotoxic chemotherapy for example, in Lee-Perrimann syndrome, where the chances of these children to have secondary cancers are higher. So these are the areas where we need to screen them genetically. So non-syndromic tumor children, it doesn't really help because we are still struggling for their financial status to get the treatment covered. We don't know what the education the child is having, whether they'll understand the tumor markers, tumor biology, what needs to be done, because the cost is I think more than 15,000 or 20,000 if we want to get those molecular tests done. There are diagnostic issues. Sometimes the patients cannot pay for the diagnostic test also. So paying for the molecular is basically difficult. I don't know how many can do for a neuroblastoma, how many places are doing NMIC amplification testing, which I think is not being done in all over India also, because the tests are not available and maybe the clinicians don't send it. There are nutritional deficiencies due to treatment, which the child has to struggle for. There's gender disparity. So when we are having these things to cover up, and the doctor, the clinician who's seen the patient should know what tests, are to be sent, what kind of tests are to be sent to check what mutation is present in the tumor also. So I think we need a geneticist or a person who's into this. I think the speakers who spoke for it have given some insights to that. So once those tests are done, there are certain mutations which can be random, which don't have any significance. So we are under a question mark whether what has to be done for that. How do we follow those? So there are no set pathways to manage those mutations. Then we need a dedicated team. When we talk about tumor tissue biology, when I was in TMS, they were taking the person who was in charge would take the fresh tumor
As soon as we took out the kidney out and any tumor we took out, the sample was taken immediately by the lab to preserve the sample and do their testing. So I think we need a dedicated team if we're talking about molecular things to be done in our setup. That can be done in a research setting or where they're already the numbers are very high volume centers. I'll skip these cases because I think they have already been discussed. So practical approach, if we can manage these factors, which will basically help providing a standard care to in the Indian setting or to the child should be followed rather than thinking that we will be doing genetic testing and we will not be able to manage the child well. Because the resources, the finances will lose on finances if we do all the molecular tests for every cancer child who comes. Thank you.
Thank you, Dr. Monica. So we have just 3 minutes. If there is any counter argument from the four people, just 3 minutes. And then we will conclude the session. The session was 45 minutes, so we have just 2 minutes.
Thank you very much. The Against team has given really nice insights. We agree that we have limitation of resources. But the limitation of resources doesn't stop us from enhancing our resourcefulness. Like Professor Sareen said yesterday, while we are struggling with malnutrition, that doesn't stop us from sending missiles into the space. Okay, ma'am, sorry. And secondly, this is the debate, okay. And secondly, we agree that we have limitations when we are talking about the clinical aspects. We are waiting for the phase 4 trials, but why do we wait for the results of trials from the Western world? That's what. So having accepted the limitations in clinics, we have to focus on the research also. We have to focus on developing an Indian database also. I'm suddenly reminded of two terms: genetic condition or a genetic disease. When we agree that in the whole subset of diseases, we have in the whole set of diseases, we have a subset where we know that this disease has a genetic basis. Alternatively, the genetic basis of the disease, where we somewhere agree that any disease, when any disease has something happening at the molecular level, which could be related to the genetic structure. If we try to be very conservative, we would never have realized the importance of WT1 or NMIC amplification. But yes, I do agree, it's a balance between what is to be done and what is not to be done. But when you talk about genetic testing, we should always keep in mind that it's not just the clinical aspects. It's not just the clinical indications. We have to balance the clinical indications with the developing an Indian database. We need to talk about research. We need to talk about population genetics or population genomics. We need to look into the ethical, legal, maybe forensic aspects as well. Thank you very much.
Thank you, all the participants. The topic for the debate was, should genetic testing be mandatory for pediatric cancer patients? So I'll conclude the session by saying that it's both ways. In the current situation, we should agree that genetic testing should be mandatory for all pediatric cancer patients. However, the treatment should not be withheld for the lack of genetic testing. We have to use our good sense and the data which is already available to see and proceed with the treatment. However, as the people speaking for have said, that we need to create database for Indian this thing. For that, we need to have trials which should be funded so that the monetary aspect of this is taken care of and the patients don't have to pay for it. So we need big trials which are well funded and to go ahead with genetic testing to create a database. And within those trials, we will have patients for whom we can do the genetic testing. So it is like rare diseases for which a lot of fund has been made available by the government. We should also work towards finding trials and money for the genetic testing. But in future, for the treatment purposes, also genetic testing would be, I think, required for a kind of individualized medicine, or you can say more specific medicine, and that is where the world is going. So I would conclude by saying, yes, genetic testing is mandatory, but we cannot withhold or defer treatment for the absence of genetic testing. So it could be done if the funds are available. And in the current scenario, probably it is not correct to ask the patients to pay for it in our scenario. Would the House agree with that? Right. Yes, thank you. So we conclude this session and.
Thank you. I would like to call upon Dr. Ankur Mandalia, sir, to present a token for appreciation to the debaters, Dr. Prabodh Goel, Dr. Manish Pathak, Dr. Arihan Jain, and Dr. Monica. We'll move on to our next session. Minimal access surgeries have become an indispensable tool in the management of most of the pediatric surgical cancers. To clear our misconceptions, I invite Dr. Sandeep Kisku, sir, Professor, CMC Vellore, for a talk on MIS and robotic surgery in pediatric solid tumors. I would also request Dr. Ankur Mandalia, sir, Additional Professor, SGPGI Lucknow, and Dr. Nijagal Mutt, sir, Senior Consultant at Bengaluru. I also request all the respected speakers to keep an eye on the time limit and the esteemed delegates to keep the discussion as short as possible. Thank you.
टीचर को फिर स्पीकर बना के मुझे चेयरपर्सन बना दो।
Yeah, good morning. So, Sandeep Kisku, I think he needs not much of an introduction. He's a professor of pediatric surgery at CMC Vellore and an accomplished MIS surgeon. So, we'd like to listen to his views on MIS in pediatric solid tumors. Sandeep, floor is yours.
Good afternoon, everybody, and thank you, chairpersons, for bring greetings from CMC Vellore. Thank you, Dr. Basant and Dr. Sushmita, for inviting me to this place, a wonderful institution. This is my first time I'm here, and thank you for the invitation again. The topic is MIS and robotics in pediatric oncology. And you see here on the slides here are, this is the robotic hepatectomy, this is the sleeve lobectomy for a child with a carcinoid. This is the left robotic hepatectomy for RCC, renal cell carcinoma, and this is a mature teratoma in the right, in the left suprarenal region. So what are the benefits of MIS? And I think I'm preaching to the converted. A lot of you know the benefits of MIS, and I won't spend time on that. Then look at the demerits of MIS, lack of tactile feel. Can this be addressed? Of course it can be. Better vision, the current robotics platforms offer us excellent vision. And that is, with that, you're able to feel with your eyes. The current generation of robotic XI, the current generation of Da Vinci has haptic feedback included in it. So yes, technology has aided in overcoming some obstacles. Specialized instruments, they're available now. A lot of commitment and training and upskilling that is necessary. That opportunities are available. These are unsuitable for large tumors, and that is true. Surgery may take longer. And that's not true for all cases. So what has been the early experience in pediatric oncology with MIS? And earlier on, it was restricted to performing biopsies, staging solid tumors, and explorations, lab exploration, then going on to seeing if if the tumor is resectable, or even resecting metastatic disease. Now, look at the chronology a little bit. 2002, this was a randomized control study in 111 institutions. This was a study conducted from 96 to 2002. And, understandably, they closed the study early. And look at the reasons: lack of interest from the ped oncologists, lack of surgical expertise in MIS. There were preconceived surgeon bias towards open surgery. There were unconfounded concerns about tuber cell disbursement with the insufflation and port side recurrence. By the way, none so far reported. Lack of instruments, lack of anesthesia strategies for one lung, and other strategies to address loss of tactile sensation. Now, you wonder whether much has changed in the last 2 decades and 2 years. 2010, an Italian group, they presented their experience, and they said a basic surgical principle should be followed, which is true in all cases, and should be the cornerstone of every patient management, which is getting good margins, avoiding a spill, and harvesting lymph nodes. And there were some specific considerations. Now, I won't go to all of these details because, as we pass by as years pass, all of these are being challenged. In 2004 and then updated in 2019, this group presented from St. Jude's Hospital, presented more than 350 cases which were done MIS. And though 60% were done diagnostic, a lot of these thoracic tumors were done primarily resected by MIS. 2018, we had this paper which looked at review of literature of 104 patients who had a laparoscopic nephrectomy for Wilms tumor. And no spill was recorded. There was a local recurrence of 3.8%, which compared to open surgery was 7.9. Lymph node sampling seemed to be similar. And they have mentioned good patient selection. Of course, there were smaller tumors, lower stage, favorable histology, and I wonder why there were no spilled. Were they not reported at all? But you get the drift. People have been doing this by the book, and it is possible. Look at 2020, MIS techniques. This was an APSA cancer committee, and they looked at MIS in abdominal and thoracic neuroblastoma. And essentially, they came out with some criteria. We won't dwell so much because I would show you a little later that these are the more advances that have been done. And then there was an APSA cancer committee guidelines on MIS for renal tumors. And they concluded that MIS should be considered only for small Wilms tumors. In 2021, Vijayan and his colleagues, they came out with some recommendations. And they basically said it should be histology-based and a few other indications. The one operation they said we shouldn't try and do is the adenocortical cancers because they're friable and we don't want to spill them because we don't have chemotherapy for that. Let's look at robotics in pediatric oncology. There's been very little adoption. There were only 31 studies of 171 cases reported until 2022. And the application is debatable despite actually growing increase in non-malignant cases. In the adults, there's a similar experience of oncological resections, margins, lymph node harvesting, for adult oncology. Unfortunately, in pediatric oncology, we made significant strides in improving patient outcomes, but the surgical expertise has largely remained the same over the last maybe 2 decades. And the reasons probably are access to robot, the cost, the high degree of skill and technique that is necessary, the training that goes behind that. Very little evidence, and that comes because there are very few studies, and the pediatric surgeons traditionally have lagged behind in technology. So why robotics? Robotics offers unparalleled 3D vision. You're able to see and feel with your eyes, an unhampered stable view, wristed instruments. The suturing or reconstruction is possible in almost every angle. There is built-in safety in the current Da Vinci systems. There's no surgeon fatigue or very little surgeon fatigue, and that directly translates into good outcomes. Ergonomics is sorted, and the whole is greater than the sum of the parts, as Aristotle said. So let's look at 2022. This study from France, they looked at 14 cases. Most of them were gynae malignancies. They had some spill, and they did a bit of thoracic neuroblastoma. 2023, we've had this paper published in the seminars in pediatric surgery, and this was that robotics should be considered for numerous thoracic pathologies. And it almost seemed that suddenly there was a door open, and wherever it was possible, the indications were expanding as per the surgeon's expertise. And in neuroblastic tumors, IDRF contraindications seem to depend on the surgeon's expertise. So guidelines were being changed. The goalposts were being changed for the recommendations. Though the surgical principles are the same, it's just that the expertise has improved. In 2024, we had this group from France again presenting 149 cases where they've been able to do many more cases, and literally they have been pushing the boundaries. And the guidelines, I want to say that one of these guidelines was, a contraindication, a formal contraindication was avoiding solid pseudopapillary tumors. But we know one of our colleagues here has done one. He probably didn't read this, or he probably was able to address those difficulties. And so I think the guidelines are being challenged and are being rewritten with passage of time. So let's look at CMC Velour's our experience. This is in the last 11 months, and we've done about 14 cases. We've had one hepatectomy, 2 sleeve lobectomies, two lobectomy and a pneumonectomy, neuroblastic tumors in the thorax, and then radical nephrectomy for RCC, and an RPLND and other cases. Now, the hepatectomy and the sleeve lobectomy would be one of those very complex cases, and it requires a lot of skill. Our total experience in robotic cases are only about 50 in pediatric surgery. So we are well in the learning curve still. Has this made changes in our patients? I believe we have changes. I will present a few cases very shortly and briefly. I don't think we'll have time for discussion, but I just want to give you a taste of what the future is. This is my group, my colleagues, and this is my unit. I had the unit in pediatric surgery, unit 3. These are my mentors, Dr. Saravanan and Dr. Vijay. Vijay helped me with the hepatectomy. So while I came to Lucknow, I found this as I exited the airport. But truly, the motivation for robotics or MIS should be that robotics enables MIS when it otherwise might not be offered. And this is a slide I borrowed from Ankur. He will probably explain more about it in a coming lecture. I have a few videos I'd like to present.
I think you have 5 minutes, Sandeep, if you can show us some videos here.
Yep. So I'll start with a suprarenal neuroblastoma. And this was a child with a metastatic neuroblastoma, post chemo. A very small lesion there, 2 into 2 centimeters. We had an MDT. They requested me to remove that. It was behind the IVC. And there was, you can see almost a 180-degree involvement of the IVC. And so this is the tumor. We were able to access that tumor. That's dissection of the IVC, separating the tumor from the kidney. Now dissecting around the IVC, behind the IVC, and removing that tumor. This tumor, we were able to remove this tumor. There was no malignant cells in that. And the child did really well. This is a child with a posterior mediastinal mass extending into his neck, infiltrating his brachial plexus. He was in severe pain, and he had to keep his hands up just to avoid the pain. You can see that he had some deficits here. We had done 2 biopsies which were non-conclusive. And so the MDT required me to go in and take off as much as possible and get a biopsy. And I planned a robotic operation because it was in the inlet and we could avoid a trapdoor thoracotomy that's accessing the tumor. Excellent vision. That what you're seeing there is the T1 nerve root. It's the T1 nerve root. And that's removing the tumor piecemeal. We were able to get into the neck from the chest. That's going into the neck from the chest. I had the hand surgeons on standby to be able to help me with that if I was not able to remove the tumor, but we were able to remove 95, 98% of the tumor. And then they said it was not necessary to do anything. The child had chemotherapy subsequently, and his repeat PET scans showed no residual disease. Ankur, you can stop me when it's 5 minutes.
Yeah, I think we just have 5 more minutes for discussion. So I think we can have discussion if you have wrapped up.
Yeah.
You want to show
one more video?
Yeah, just quickly, if you can
Yeah.
just run through the video. This
Okay.
last video.
Okay. So this is a robotic hepatectomy I just recently performed for a child with a 12-centimeter mass in the right lobe of liver. This was a biopsy was done. It was a hepatic adenoma. It was previously embolized elsewhere. And the operation proceeds the same way it is done open surgery. We get the vascular isolation. That's the hepatic artery, the portal vein, right branch of the portal vein. Okay. And this tumor was so large, we were not able to flip it the other side to get the short hepatic veins, but the hepatic veins are addressed. Everything proceeds just like the open operation. That is ultrasound guided marking of the middle hepatic vein. Here's the transection. We use a vessel sealer, excellent device, absolutely amazing device. We were able, that's the, now here's some bleeding of the short hepatic vein. I'll just show you. There's a lot of bleeding there. We had some heart-stopping movements, but I won't tell you how we did it because I'll reserve that for PESI. And that's dividing the tumor, and eventually that's the normal left lobe. And I didn't do much. I'm sorry.
You can.
Okay. Okay. So yeah. So that's the outcome. So has MIS made a change in my patients? I believe so. We are still on the learning curve. It has avoided, in some cases, a large thoracotomy, a large abdominal incision. Parents want an MIS operation. We have the skills and we have the resources. And so that's where we are. And I suppose there will be more in the future.
Thank you, Sandeep. That was excellent talk and excellent videos. Good review of literature. So one takeaway from me, what you said, is mimic the open procedure. I think that is the basis of MIS for not only oncology, for other diagnosis as well, but we are in an oncology meeting, so let's talk oncology. So mimic the open operation and you'll be okay.
Absolutely
Right.
no compromise on surgical surgical principles here. It's just the approach, but the approach requires a lot of skill and a lot of planning and teamwork, and it's possible.
Yeah, so Professor Piotr showed a couple of fantastic videos yesterday, so we have time for a couple of comments. Maybe sir can take one comment.
First of all, congratulations on your bravery. Because, you know, being on the learning curve, you select the difficult cases. Because usually you try to start from easier ones before you master the technique, but the hepatectomy, absolutely, congratulations. And I agree with your basic message that robotic surgery can move the curve, the Gauss curve of minimally invasive surgery, because robotically, I think, that's my opinion, we will be able to do the cases which we would never be able to do laparoscopically. And I think that's, in the beginning, I was not so much fan of robotics. And I said myself, you know, if you are capable of doing advanced laparoscopy, you can suture, if you can do thoracoscopically esophageal atresia, you're capable of intracorporeal nothing. Why go into robotics? Right? And it's a nonsense. But after this pancreatic surgery case, I know this is not true. I was false. Because the degree of stabilization and precision is much higher than in laparoscopy. And that definitely extends your range of capabilities and the range of cases you can do. So I fully agree with your main message.
Yeah.
And one question. What was the indication for rectoperitoneal lymph node dissection in James 13, where the vesicular tumor, were the lymph nodes involved?
Yeah, so this was a child with a 12-year-old child with paratesticular rhabdomyosarcoma who had lymph nodes, and he had his treatment. There was still some residual disease. They wanted him to do an RPLND, and that was why it was done. So with regards to MIS being offered, this is one of the sleeve lobectomy children, and this is a very difficult operation to be done VATS. I've not done a VATS or a thoracoscopic reconstruction. I wouldn't have been able to do this, but with the support systems that we had, we were able to complete this robotic, and not just one, but two of them. And so it certainly extends the ability of the surgeon to offer MIS for patients in complex cases.
Also the technological advances, you showed ICG in a couple of videos. So the criticisms earlier say for a Wilms tumor where the lymph node yield was quoted as a reason for not doing MIS. Actually, now there are papers which are showing with the use of ICG, the lymph node yield is actually more than open surgery. In the paper you showed, it was 4.65 versus something, a lower figure in open surgery. So actually the yield is as good, if not better, than open surgery. So the technology is there now to do these advanced cases. Yeah, Anjan, you have wanting to have a point.
Congratulations on that excellent videos and presentation. Just one query I had, like in the hepatectomy case, where it was a large one, it was actually extending. How do you make sure that, like when we do in open procedures, wherever we take a lot of palpatory cues as to get to the margin, you know? So how do you get to know that you are not going through or very close to the margin when you do robotically?
Yeah, so you have intraop ultrasound to be able to guide you.
Okay.
And
So that technology again comes into the picture.
So also I had studied the CT like the back of like the back of my palm, because the middle hepatic vein was well away from it. So I stayed on the middle hepatic vein.
The landmarks
and you would do it just like you would do it open surgery. Robotic surgery is open surgery with instruments.
Also, the next phase is the real-time imaging being projected on the robo. That is already there, not
so
in clinical use. So you can now project the CT on your console
Augmented,
and will augment what you're seeing. So all that is already there. It will come into clinical practice in the next 12 to 24 months, sir.
that should show, yes, absolutely.
We use it here. We use it here.
So then you have like an extra confirmation.
Yes, yes, we use it here.
But it's not which I think is an absolute highlight and its direction for the future. It's image guided service.
Yes.
And it's the use of ICG, we are using extensively now. And it's extremely useful and it's something you should discuss in details. And it's not that expensive. I mean, expensive equipment.
ICG is actually cheaper in India. Yeah.
So, and there are many new dyes and fluorophores in development, which will be tumor specific.
Yes.
So it's
Agree.
a revolution which is taking place right now. I think we should discuss it in the next topic.
Yeah. So any other questions, or I think we are running short of time, so we'll wrap up this session. Thank you, Sandeep, for an excellent talk again, and thank you for your participation. Thank you.
I request our chairpersons, Dr. Ankur Mandelia and Dr. Nijagal sir, to continue for the next session. Advanced radiotherapeutic options in pediatric solid tumors. And speaker for this session is Dr. Punita Lal, Professor, Department of Radiotherapy, SGPGI.
Thank you. Good afternoon, everyone. Let me begin by thanking the organizing team, Dr. Basant and everyone. I've been asked to be to the point and hurry up if you want to have lunch on time, which I will definitely try, especially because I think to keep the interest of surgical audience on a topic such as this may be a bit of a challenge. So we know that the childhood cancers are rising, and so are the cure rates, in fact, dramatically so. And the reason being that we all know that we have adopted multimodal approach of treatment in these tumors. Radiotherapy is one of the integral part of treatment whenever we talk about multidisciplinary approach, and it's given in host of situations in pediatric cancers. The reason why radiotherapy still holds the ground, even though we keep hearing dissuading and discouraging notes about it, is because these tumors are highly radiosensitive. You can use radiotherapy in adjuvant setting because it's very effective in taking care of the microscopic residual disease and decrease the locoregional failures considerably in post-operative setting and in spillage settings and all. Metastatic radiotherapy, for instance, in WILM, in pulmonary radiotherapy is given not just in palliative setting, but in radical setting as well. And in palliation, of course, whether be it children or adults, it has a profound role to play. The procedure of radiotherapy does not change in pediatric setting, but there are certain specific and unique issues that we need to be cognizant of in childhood cancers. For instance, children have lower tolerance to radiation. And one of the reasons for lower tolerance to radiation is that the target volume, the volume that we are going to irradiate is in a small body. So the proportion that gets irradiated is much more, and therefore the toxicity is much more. We are a very machine dense department in all centers, and the children tend to get overwhelmed. They need to be brought into the machine setting 2 to 3 times before they get used to and acclimatized. The child has to be alone for about 15-20 minutes in a room, and the child has to be still. So we need support of our anesthesia colleagues for sedation or short anesthesia. Immobilization has to be to the point in these children. course, in children, we all know we have high cure rates today, and that means that there is longer lifespan, which also means that late effects do get manifested, and they may not be life-threatening, but they do impact on the health and the quality of life significantly. For instance, after radiation, we do encounter growth retardations, endocrinopathy, cognition decline. These are common things. And as years go by, the risk of second malignancy because of radiation or due to the alkylating agents or transplantation is also a common phenomenon. Late effects do manifest. They appear months or years after treatment, and usually they're a part of developmental process. Sometimes when one of the compensatory mechanism fails, that we get to see late effects. For instance, in this child, where the right side Wilms was treated with flank radiotherapy, if a better sort of focus would have been, attention would have been paid, we might have been able to avoid this scoliosis in this child. So there are hosts of late effects of treatment which we need to monitor, and that's where we actually spend our time trying to maximize cures with radiation and minimize these long-term toxicities. But radiotherapy landscape is definitely changing thanks to the molecular diagnostic. We just talked about a lot of it, precision imaging that has come, advent of newer and newer agents of chemotherapy, and the risk adapted across the board risk adapted approach that we have of treatment. Like we will see in medulloblastoma, we see quite routinely. And that has helped us to maybe in a certain number of cases, delay radiotherapy or omit radiotherapy till the time the child is older. We may decrease the doses, de-intensify or de-escalate radiotherapy is also something that we've been doing. So if I could say the advancements have been that apart from better understanding of the molecular tumor biology, advent of more and more of effective chemotherapeutic agents, diagnostic imaging, the researchers have worked a lot on patient positioning and immobilization, different advanced techniques, better technology, and dose reduction strategies. So like I talked about, positioning and immobilization takes a lot of our time. This is the vacuum bed that we have individualized for each child so that he or she lies comfortably in this, and this position is reproducible on each fraction each day. And apart from that, we have other accessories like if this area has to be treated, we have to make this area still, and so a comfortable neck rest for the child, and a thermoplastic cast so that there is no movement while the patient is being irradiated. Lot of novel therapies are now into practice, like intensity modulated radiotherapy, image guided radiotherapy, arc therapy, hyper-arc therapy. All are to do with the fact that we should treat the tumor precisely, conformally, and conformally avoid the healthy tissue as far as possible in these growing children. Stereotactic is also something that we've been doing in children as well as in adult, and there is enough data to show that there are better controls, local controls, especially in certain cohorts of patients with minimal toxicity. Of course, all these high-end techniques require infrastructure, they need training, they need team efforts, they are labor-intensive in the pre-planning and the planning phase, and they are time-consuming in the treatment delivery phase. Similarly, for helical therapy, a very sought-after therapy in photons when we are dealing with long segment therapy like in craniospinal irradiation in medulloblastoma, highly conformal, and we treat slice by slice. Each slice is first verified and then treated. So it's a very popular technique. I wouldn't go into much of this because this has taught us a lot. It's been a good model for us. And we've learned that there are, thanks to the molecular approach, there are subtypes where we can de-intensify therapy or reduce our doses. And we've worked on a lot of immobilization and the positioning of these patients in photon beam. I'll talk about protons in a while. Similarly, in lymphomas, We used to treat by radiotherapy using mantle technique or inverted by treating all the likely sites of involvement. And we've come down thanks to the better techniques, better imaging, use of FDG PET, and use of good chemotherapy that we talk about, treating only the involved nodal anatomy to consolidate the gains of chemotherapy. If we talk about metastatic films, the pulmonary radiotherapy NWTS was using X-ray defined metastasis, and pulmonary RT was radiotherapy used to be given. Today, SIOP under the umbrella protocol has recommended that we use CT scan for the thorax and identify these small nodules. These nodules, if they vanish after chemotherapy, good use of doxorubicin, and then those are the good cases where we can omit lung RT where we bathe the lung and the heart is the innocent bystander in these. So we could omit in certain cases, and that's very valuable for us. In those where we cannot, heart-sparing IMRTs are being used, especially because we are aware that we're using anthracyclines in these tumors. So these are the new techniques. The blue area that you see is where no dose has been given with the use of intensity modulated radiotherapy, while yellow and greens are where the lungs have been bathed with radiotherapy. Retinoblastoma is no different. When I was a resident, we used to treat lots of retinoblastomas with radiotherapy, probably giving them a lot of HICs, bone hyperplasias, and second malignancy. Today, with chemoreduction strategies like intraarterial therapy and focal therapy, the role of external beam radiotherapy is now limited to persistent and relapsed lesions and posteriorly placed lesions. The amount of workload that we have is no less. If you can see, each thing is done so precisely with the millimeter accuracy that we need to do in these children if we wish to preserve the vision in them. Now let's talk about the future, which is here, it seems, for at least for the pediatric cases. The world is really excited with the use of proton therapy in pediatric cancers, though the availability is very limited. But the advantage with proton therapy is that the beam just stops after where you want, and so you do not get any excess dose beyond where you have placed your target. Unlike the photons, where the photons keep continuing and the healthy tissue does get radiotherapy. So this is something exciting. Of course, the availability is very limited and the cost is astronomical even today. And this is just an example to show you that in craniospinal radiation, if we've treated by photon, the underlying structures, heart, GI tract, everything is getting a certain amount of dose. But with proton, you are able to escape. Similarly, studies have been done and they've shown that if we were to spare, say, the cochlea for hearing at a later date, by conventional radiotherapy, you give 100% of the dose. You go ahead with IMRT, you bring it down to 33%, and proton brings it to 2%. So it's something very promising. That's all one can say at the moment. So in the end, this is my last slide, and I'm going to talk about this, is just put my part of the story. We spend a lot of our lifetime, professional lifetime, on this machine and keep working on the technology, the techniques, and the logistics that are related to this machine. Most of us derive our experience from adult and geriatric oncology. And those of us who get interested in pediatric radiation oncology, we glean that information and use it in pediatric cases. But we must remember that children are not small adults. And if we wish to work on it, we need better teams and more support from all quarters. And this is just a room that we have created very recently for our children who come to for their pediatric radiation. Thank you very much for your kind attention.
Thank you very much, ma'am, for enlightening us. Ma'am has been a pillar of support to our department over the years, and we have managed various kids with difficult tumors, and Thank you, ma'am, again for enlightening us. So any questions from the floor, points for discussion? We don't have time for discussion. Okay, so we'll conclude this session. Thank you very much for participating, and Priya, you can announce the next session.
Requesting Dr. Rohit sir and Dr. Anju ma'am to present a token of gratitude to Dr. Punita Lal ma'am, Dr. Kalvi and Dr. Nijagal ma'am. And now we'll move on to the second three-paper session. To chair this session, I would like to invite Dr. Deepak Khandpal sir, Senior Pediatric Surgery Consultant from Lucknow, Dr. Vijay Kundi sir, HOD, AIMS, Jammu, and Dr. Nitin Pant sir, Professor Junior Grade from KGMU, Lucknow. So there will be 4 minutes given for the talk and 1 minute each for discussion. So kindly present in time. And the best 3 presenters will be awarded. So chairpersons are requested to evaluate accordingly. Dr. Priyanka, are you ready?
Yeah, sure.
Good morning, everyone. My name is Priyanka. I'm a research scholar in AIMS New Delhi in the Department of Pediatric Surgery. I'm presenting study of clinical significance of genetic alterations and feasibility of adopting COG risk-based stratification of Wilms tumor in Indian children. Wilms tumor is one of the most common renal tumor in childhood. Their primary prognostic factors include tumor histology, stage of the diseases, patient age, tumor weight, and the response of lung nodule after the 6th week of the chemotherapy, and the presence of molecular marker 1P and the 16Q for risk stratification. On the other hand, SIOP utilizes histology response tumor volume for the risk stratification. The molecular marker 1P and the 16Q are strongly associated with the poor survival when these two present both together. But in the UK study, only 16Q associated with the poor survival. On the other hand, 1Q gain, which is present in 28% of the cases in both COG and SIOP study, leading to lower event-free survival and overall survival.
So we planned our study to assess the correlation between 1Q gain, LOH 1P and 16Q and their association with the histology stage and the patient outcome. We conducted our study from 2019 to 2023 in the consecutive case of Wilms tumor, and the patient were evaluated according to the histology stage and genetic alterations. In the histology, we included favorable, unfavorable. In the unfavorable, we included focal anaplasia, diffusion anaplasia, and blastomal predominant. In the genetic alteration, we included 1Q gain, LOH at 1P and the 16Q, and other genetic marker also which not included in this study by MLPA technique. And the primary outcomes were 4-year overall survival and event-free survival. Let's talk about the result. We included 68 patients of the Wilms tumor. Their male to female ratio over 1.65:1, showing male predominant. The mean age was 46 months. If we talk about the stages, we have seen that stage 3rd and stage 4 were prevalent, and early stages, stage 1 and stage 2 were less common. If we talk about the genetic alteration, 1Q gain was present in only 19% of the cases. LOH 1P and the 16Q were present in 26% and 25% of the cases respectively. But the combined LOH 1P and the 16Q were present in just 1.5% of the cases, all of whom with stage 4. If we talk about the outcomes, 4-year overall survival was 83% and 4-year event-free survival was 78%. And when we look the histology, we have seen the significant impact on the survival outcome. We have seen that favorable histology have a better survival as compared to unfavorable histology. And if we assess the 1Q gain, 4-year overall survival and event-free survival were lower with 1Q gain as compared with without 1Q gain. So we concluded that 1Q gain was present in only 19% of the cases, but we did not any significant impact on the survival we didn't show. And on the other hand, unfavorable histology and advanced stage significantly affect on survival outcome. So implementing COG-based risk stratification, 1Q gain and LOH 1P and the 16Q will need larger cohort to assess utility in the Indian population. Thank you.
How do you correlate it with the world literature regarding this LOH 1P 26% and 16Q 25%? The survival.
So we tested MLPA technique. So we have seen that in the normal patient, we didn't show any alteration. And the above chart is the patient chart in which the 1Q gain is prominent. In the x-axis, we have a loci of the chromosome, and in the y-axis, we have a probe doses composition. And in the second section, we have a probes. If these probes are up, if they cross the blue line, that means there is a addition of the chromosome. If these probes cross the red line, that means there is a decrease in the chromosome. Then we correlate with the normal patient. In the normal patient, we didn't show any alteration.
Anyone from audience, any question?
Okay. Can we have the next speaker, please?
Thank you.
Dr. Losu from LHMC, New Delhi.
Good afternoon. Implementation of multimodal treatment protocols has made Wilms tumor one of the most curable childhood cancers. The ICMR guidelines for the management of Wilms tumor found PSYOP approach more feasible in the Indian scenario. However, most of the Indian institutions have been using hybrid technique. Whichever approach one may choose, the idea is to have excellent outcomes within the given local constraints. Our aim was to do a short-term outcome analysis of patients with Wilms tumor, and our objective was to study the overall survival and event-free survival in Wilms tumor patients. A retrospective study of the outcomes in Wilms tumor patient was done after IEC approval. All consecutive patients treated by a single senior surgeon for Wilms tumor over 3 years were included. Modified PSYOP protocol was followed, in which all patients presenting with renal tumors other than a neonate underwent pre-therapy image-guided cutting needle biopsy, abdominal ultrasound at presentation, and CCT scans of chest and abdomen, both pre and post NECT along with tumor volumetry were done to assess the tumor response to NECT. Pre and post of DMSA was done in all patients undergoing NSS, and subjective decision to do NSS versus radical nephroureterectomy was taken by the senior surgeon. Multimodal treatment with emphasis on nutrition were implemented. Our treatment strategies were that chemotherapy was administered on an in-house basis. Adjunct chemotherapy, radiotherapy, and nutritional supplementation were made available free of cost. Pathologists and radiation oncologists were involved preoperatively, which reduced the histopathological reporting time and allowed radiotherapy to be started within 10 days of surgery. And strict follow-up of patients while on and after completion of treatment was followed. 23 patients were included in our study. The male-female ratio was 16:7. Median age at presentation was 32 months. 19 were unilateral and 4 bilateral. 1 patient had WAGR syndrome. 19 were localized and 4 metastatic. All patients except for 1 neonate underwent pre-therapy CNB and were subjected to neoadjuvant chemotherapy. The median pre-therapy tumor volume was 1,023 ml, and the median post-NECT tumor volume was 612 ml. Only half had more than 40% reduction in the tumor volume burden. Surgery was done within 1 week of completion of neoadjuvant chemotherapy. Radical nephroureterectomy was done in 17 renal units and NSS in 10 renal units. Frozen section of lymph nodes and surgical margin was done for all patients undergoing NSS. There was no intraoperative tumor rupture noted, and all but 2 cases were had free tumor margins. Other surgical steps were also done. This table shows the correlation of the histological type and the overall stage to the outcome. And we can see that in patients who had localized Wilms tumor, the outcome was not affected by the histological type and the overall staging. But in patients who had stage 4 and 5 disease, the overall prognosis was poor. Adjuvant chemotherapy was completed in 8 patients. 2 are still on chemotherapy and 6 patients received flank radiation. 4 patients had bilateral Wilms tumor, out of which only 1 is alive and on follow-up. 4 patients had metastatic Wilms tumor. 2 had pulmonary mets, both are alive and on follow-up, and liver metastasis was seen in 2 patients and both expired. 3 patients had recurrence. 2 had recurrence in the renal bed, and 1 had metachronous Wilms tumor in contralateral kidney and expired. 1-year OS and EFS was 84% and 76% respectively, and 2-year OS and EFS were 77% and 76% respectively. To conclude, the ideal management of Wilms tumor requires a multidisciplinary approach, judicious use of well-established protocols, and diligent compliance with treatment and follow-up. By our short-term results for localized unilateral Wilms tumor were excellent, but our results in stage 4 and 5 were disappointing. Good prognosis was noted in patients with pulmonary alone metastasis, and poor prognosis was noted in patients with liver metastasis. Thank you.
Any question from the audience? Thank you, Dr. Luz.
Just, I'd like to ask you, you did a true cut biopsy, I suppose?
Yes, sir.
In every patient, irrespective of the stage?
Yes, sir. So actually keeping in mind that the incidence of non-Wilms renal tumors are quite high in South and Southeast Asia. So keeping that in mind, and also the fact that the PSYOP-based neoadjuvant chemotherapy does not work on these tumors. So keeping that in mind, we do a biopsy in all patients prior to starting the treatment.
Thank you.
Next, Dr. Shobha.
Good afternoon, Chairperson and all delegates. I am presenting a paper on a single center experience of clinico-pathological spectrum of pediatric ovarian masses. Ovarian tumors in children are rare, comprising 1% of all childhood malignancies, the most common of which are gynecological tumor, ovarian tumor, most are benign, 2/3, and mostly are germ cell tumors, which are mostly teratomas. In malignant tumor, York sac tumor are the most common. The surgery that we offered was oophorectomy with or without salpingectomy. Clinical presentations were variable and mostly presented as abdominal mass. The aim of my study is to report clinical profile, radiological profile, management, and outcome in pediatric ovarian masses. This was a retrospective study done in last 10 years. Records of all children with ovarian masses were managed in department were reviewed. The basis of this study was age at presentation, clinical features, surgical procedure, need for neoadjuvant chemotherapy, post-operative chemotherapy, histopathology, and outcome. Total 48 patients, age range was from 4 months to 15 years, and the most common clinical presentation was abdominal lump, followed by pain, followed by acute abdomen, among which 45 presented as primary cases and 3 cases presented with recurrence in contralateral ovary. These are the images of ovarian tumor presenting as abdominal mass. These are histogram of tumor markers of 11 patients in which AFP was raised in 4, LDH in 3, CEA in 1, and all 3 were raised in 4. On CECT whole abdomen, 33 cases were primarily originating from ovary and 11 were equivocal. This is an axial CECT image showing right ovarian tumor, while the next slide is of left ovarian tumor. Among the 40 patients, primary surgery was done in 31, and in which oophorectomy was done in 31, and salpingo-oophorectomy in 17. 8 patients received 4 to 6 cycles of neoadjuvant chemotherapy. In 5 patients, mass was found to be adhered to adjacent structures, 3 to bowel and 2 to bladder. Post-operative chemo was given in 14, including all 8 with neoadjuvant. Out of 48, 30 patients completed 5 years follow-up with optimum outcome. These are the histopathology in which mature germ cell tumor, which were maximum, it was 10, followed by mature cystic teratoma and mature teratoma. These are the histopathology slides of York sac tumor and dysgerminoma. In our study, most of the ovarian tumor presented with abdominal mass in contrast with other studies, and similar to other studies, majority are germ cell ovarian tumor. Pediatric ovarian masses are mostly benign and most commonly germ cell tumor. Surgery is the primary treatment for almost all the ovarian masses. With combination of cisplatin-based chemotherapy with surgery, a good outcome can be expected in majority of ovarian tumors. Thank you.
Any questions from audience? Dr. Nishant Agrawal.
Good afternoon, everyone. I am Dr. Nishant Agrawal from HGPGMS Lucknow. I am going to present the management of Wilms tumor, a 5-year experience and outcome in a single center in North India. As we all know, there are more than 90% of the Wilms tumor which are diagnosed before 5 years of age, with the median age of diagnosis at 3.5 years. There are 5% of the childhood tumors which consist of renal tumors, in which 80 to 90% are Wilms tumor. The 5-year survival in developed nations are about 90 to 95%, and in developing nation like ours is about 75 to 80%. So my aim is to evaluate the outcome of patients with Wilms tumor in a single center over 5 years. So this is a retrospective study. We have reviewed electronic medical records of the children treated in SGPGI with Wilms tumor from January 2019 to January 2024. The records were reviewed, demographic data, clinical presentation, radiological assessment and management and follow-up were recorded. So we found there was total of 25 patients which were treated, in which 18 were male, 7 were female. The age range was between 7 to 105 months with a median age of 36 months. With clinical presentation, 21 patients presented with abdominal mass, in which 18 were asymptomatic abdominal mass, 2 presented with fever, and one had hematuria. 2 patients presented with pain abdomen, and 1 was incidentally detected. 2 was incidentally detected. And the 4 patients in 25 patients had a hypertension on presentation. So there were lesion was 12 on the right side, 11 in the left, and 2 were bilateral. So we did a clinical pathological, surgical pathological staging, in which there were 6 in stage 1, 16 patients in stage 2, 1 patient in stage 4, and 2 patients in stage 5. The histopathological risk stratification was done, in which it showed intermediate risk in 21 patients and high risk in 4 patients. So the operative summary which we performed 17 cases, and we performed a classical nephrouretectomy with lymph node sampling. In 5, there was a vascular extension. So we did a venotomy and extraction of the thrombus. And in 3, we did a nephron sparing surgery. In 2 were bilateral. So the outcome, we have a follow-up of 8 to 60 months with 21 patients are alive at present. 20 are without any active disease. 1 had pulmonary mets for which chemotherapy is being given. 3 patients died, in which 2 were died during the treatment and 1 got liver mets. And the 1 patient lost to follow-up during COVID period. So to conclude, the prognosis and long-term survival of this tumor has improved over decades. Issues like delayed presentation, malnutrition, lack of access to treatment, supportive care, and lack of social support in resource-limiting countries like ours still plays a crucial role in overall survival. Thank you.
You said 2 of your patients were detected incidentally.
Yes, sir.
Can you tell me the scenario? Because in our setup, I mean, incidental detection of a Wilms tumor.
Sir, incidentally detected, they just went to regular follow-up for 2 pediatricians. A regular follow-up to pediatricians. So the pediatrician detected that the child is having some abdominal mass.
I mean, a contralateral kidney, you mean?
No, sir, no contralateral kidney. Sir, for the unilateral kidney only. Like some patients go for regular follow-up to the patient, like for vaccination and for other things. So then they were detected.
Can you comment upon the lymph node sampling? How was it done?
Yes, sir. Sir, we have taken in every patient 7 stations of lymph node. We have taken the 2 stations, the 7 stations were suprahilar, para-aortic, paracaval, inferior para-aortic, paracaval, 2 iliacs, and 1 mesenteric node were taken.
Any question from audience? Thank you.
Thank you, sir.
Next paper, Dr. Arihan Jain.
Good afternoon. Myself, Dr. Arian. I will be presenting a paper on delay in instituting local therapy, which is surgery and radiotherapy in pediatric solid tumors, a retrospective study. The background is that delayed diagnosis and treatment is a result of, it can result in poor outcomes in pediatric solid tumors, and which lays over the importance of multidisciplinary care and equity of access, and timely institution of local treatment modality is very crucial. The aim was to estimate the delay of more than 2 weeks in surgical intervention or radiation therapy required in pediatric solid tumors, and to investigate what were the causes in the delay in instituting the therapy. It was a retrospective observational study, cross-section study conducted over a period of 7 years, in which we have included the patients from 2014 to 2022 and those who have completed the treatment till 2024, and a follow-up of 4 years. Patient of between 0 to 18 years of age were included in the study, and those who were given neoadjuvant chemotherapy were included, and those who underwent upfront surgery or were on a palliative care were excluded from the study. total 92 patients were registered. Out of 56, up to those 56 were included and were given new adjuvant chemotherapy. 37 patients underwent post-chemo surgery, 16 underwent radiation therapy, and 3 underwent both surgery plus radiation. And out of 37 patients, those who underwent surgery, 24 had surgery outside the hospital, and therefore they have 17 of those patients had a delay in undergoing surgery. And out of the patients who had underwent surgery in our hospital, our center, there is a delay of 11 patients. And in patients, those who had those require radiation therapy, they had six patients had delay in instituting the radiation therapy. 92 patients, this I have already told. So the distribution of the tumor was that there were 18 patients with Ewing sarcoma, 15 with osteosarcomas, 10 were Wilms tumor, and 2 patients were of neuroblastomas and Wilms tumor. And so the 37 patients underwent surgery only. Radiation therapy was given to 12, and 3 undertook both surgery and radiation therapy. Out of the patients, surgery was delayed for more than 2 weeks from the scheduled date with a range of 15 to 51 days in 20 patients. And 1 patient with osteosarcoma specifically had a febrile neutropenia, osteomyelitis after surgery, after chemotherapy, and sepsis-induced cardiomyopathy, resulting into delay of surgery to 137 days after the diagnosis. 6 out of 15 patients had a delay in radiotherapy with an average delay of 16.5 days. The primary reason which came out to be is the febrile neutropenia and cytopenia, which were seen in 5 patients. 8 patients had surgery at another hospital and were lost to follow-up, delayed follow-up. And due to COVID, 2 patients had delay in initiating local therapy, and patient-related factors like unavailability of a surgeon at the center where I work, or the facility at the time of surgeon, and travel constraints, because most of the patients are coming from Jammu and Himachal Pradesh to our center in DMC Ludhiana. The mean time of delay for the surgery group was 22.62 days, and the mean time of delay in radiation therapy was 16.5 days. But there was no statistically significant difference in the outcome of survival, expired, and relapsed cases in surgery. Out of total patients, 15 patients that expired in the delayed surgery group patients, and 7% of the patient had relapse. Most of the relapses were of sarcomas, and in radiation therapy, 8% patient expired, and rest of the patients are surviving at 4 years follow-up. So the delay in instituting local therapy has to be investigated more so that the capacity can be built, and it will facilitate us in strengthening the referral and referral back system, so the patient doesn't lose interest in between and taking the treatment, or there should not be any loss to follow. Thank you.
Thank you, Dr. Aryan. Just one question. As far as surgical results are concerned, it's not statistically significant. Regarding radiotherapy, reason could be the time delayed availability of these radiotherapy services, or what are the other reasons, and how can we counter that?
The main reason was the delay, non-availability of radiation therapy, and patient was not fit to undergo radiation.
Thank you. Any question from audience? Thank you.
Thank you.
Dr. Sugandha Agarwal.
Good afternoon. Greetings from AIMS Delhi. Today I'll be presenting the outcome of children partially treated elsewhere for extracranial malignant germ cell tumors who were then treated at a tertiary care center. So our study included the prospectively maintained data over a 3-decade period of children below 14 years of age who presented to us after initial treatment being received elsewhere. Chemo-naive patients were treated with first-line chemotherapy, while those who had progressive disease got second-line salvage chemotherapy. Captain-Smith survival analysis was done for 5-year overall survival and event-free survival. Starting with the descriptive analysis, our analysis included 66 children with a median age of presentation of 30 months. 46 of them were males and 20 were females. Majority of the tumors were gonadal in location, in which testicular was the most common location. Extragonadal comprised 31% of the tumors, and sacrococcygeal site was the most common in them. The endodermal sinus tumor was the most common histology that we encountered in these tumors. According to the COG grading, majority of the children presented to us at stage 4, followed by stage 3, stage 1, and then at stage 2. Maximum of the children had metastasis at single site, total number being 24, and maximum had a recurrence at local site, followed by retroperitoneal lymph nodes, and one case each of lungs, mediastinum, omental, and inguinal lymphadenopathy. Metastasis involving multiple sites included 52% of the children, and they had various combinations including local, lungs, liver, retroperitoneal lymph nodes, mediastinum, bone marrow, and skeletal metastasis. Coming on to the treatment plan, 63 children were administered first-line chemotherapy in view of inadequate chemotherapy being received elsewhere. Majority children received 4 cycles of PEB chemotherapy followed by surgical resection and another 2 cycles of PEB adjuvant chemotherapy. Salvage chemotherapy was administered to 12 children in view of progression while on PEB, and it was decided in MDT according to the RACES criteria and rising AFP levels. 8 out of 12 children were salvageable following the therapy, and these were the various chemotherapy regimens that were used. Coming on to follow-up and survival analysis, 46 children were disease-free at a median follow-up period of 17 months. 5 were lost to follow-up, while 3 were palliated for progressive disease. 12 patients had expired, and 4 of those had received salvage chemotherapy. We had a 5-year overall survival rate of 78.2%, a 5-year event-free survival rate of 17%. According to the staging, the 5-year overall survival of stage 1 and 2 reached 100%, stage 3 was 75.4%, stage 4 was 76.2%. However, it doesn't came out to be statistically significant. The 5-year overall survival of those patients who had received salvage chemotherapy was 60%, and those who had not required salvage chemotherapy was 79.5%, and it came out to be statistically significant. The 5-year overall survival of chemo-naive patients was 76.9%, and those who had not received chemotherapy before had a 5-year overall survival of 0%, and it was statistically significant. Coming on to discussion, a recently published Indian study describes a favorable outcome of MDCT with 5-year overall survival of 84.7% and event-free survival of 69.9%, and poor prognostic factors were stage 3 and 4 disease and extrapyramidal site of tumor. An international study recently published also has an overall survival of 94.13% and 5-year event-free survival of 82.33%. And poor prognostic factors identified are mediastinal tumors and AFP levels greater than 10,000 nanogram per liter. Our group presents a unique population in whom OS and EFS varies according to the stage, salvage chemotherapy provided, and events as defined by recurrence, progression, and death. Multicentric studies are required to identify poor prognostic factors in this population. Concluding, I would like to say that partially treated MDCT pose a difficult challenge, especially those who have received chemotherapy before. Chemo-naive patients usually do well, while patients who have had chemotherapy before and recur or progress usually are difficult to salvage. And salvage chemotherapy should be promptly be used when patients progress on first-line chemotherapy. Thank you.
Any question from audience? Dr. Ankur.
Yeah, I like this slide very much. Thank you.
Thank you.
Thank you.
Next, please. Dr. Preeti Kumari.
Good afternoon, respected chairperson. I'm presenting point of techniques of nephron-sparing surgery in bilateral Wilms tumor and its outcomes experience with 12 cases. Wilms tumor is the most common primary malignant renal tumor of childhood and 6% of all pediatric tumors. Bilateral Wilms tumor comprises 4 to 13% of patients. Currently recommended treatment in synchronous bilateral Wilms tumor is neoadjuvant chemotherapy followed by nephron-sparing surgery along with completion of chemotherapy to achieve optimum outcome with maximum tumor-free renal parenchyma. Anatomical basis for nephron-sparing surgery is kidney has segmental anatomy and each segment supplied by individual segmental artery. If we ligate any segmental artery, it does not compromise other segmental blood supply. However, renal vein runs with collaterals. The aim of the paper to report technical points of nephron-sparing surgery in 12 patients of synchronous bilateral Wilms tumor and its outcome. In the last 20 years, 12 patients of synchronous bilateral Wilms tumor underwent nephron-sparing surgery after receiving 6 to 12 cycles of neoadjuvant chemotherapy. 3D angiography was done preoperatively and post-operative chemotherapy was given in all. This is a child who had 6 cycles of neoadjuvant chemotherapy preoperatively, having large right flank mass and small left flank mass. This is the 3D CT angio of the child showing a right renal tumor involving upper and middle part of the kidney and lower part is tumor free with vessels relations. This is the posterior view of left kidney having tumor in the middle part. Both kidney was approached transperitoneally via large transverse supraumbilical incision. Here we can see both tumor-bearing kidneys, left and right side. After isolating the right kidney from its surrounding structure, it is draped in a sterile slush of eye slush of ringer lactate. This is the anterior view of the right kidney and posterior view. After identifying the segmental arteries supplying the tumor as identified, ligated and divided anteriorly and posteriorly, it creates a line of demarcation between tumor bearing area and normal parenchyma. Along this line, we resected the tumor from renal parenchyma and leaving the normal parenchyma, repair the bleeding vessels and open collecting system with nephrostomy tube in place and renography completed. This is the left kidney showing tumor in the middle part of the kidney and segmental artery ligated divided and enucleation of the tumor was done with repair of the bleeding vessels and open collecting system. Complications outcome measured includes complication during surgery and post-operative period and tumor recurrence at follow-up. In the result, nephron-sparing surgery is done in 21 kidneys and enucleation of tumor in 3 and no leak in post-operative period and none had post-operative oliguria. In the result, all patients except 3 had favorable histology, 2 had recurrence of tumor during follow-up and managed with stepping of chemotherapy. 1 patient died due to chemotherapy-related complication. So we concluded with prior knowledge of segmental anatomy of kidney and selective ligation of segmental arteries to tumor, nephron-sparing surgery can be safely performed in bilateral Wilms tumor without any complication. Thank you.
Good study. Any question from audience? Yes, please.
Yeah, good study, nice pictures. You showed that you have done a segmental ligation of the vessels and then done the NSS.
Yes, sir.
Did you clamp the main pedicle?
No, sir.
Then what is the point of putting the kidney in the ice slush?
For cold ischemia.
Cold ischemia is when you clamp the main pedicle. If you don't clamp the main pedicle and you're just ligating the segmental vessels, what is the point of putting the kidney in the ice slush?
You have to take control of the vessels.
Yeah, that is so. It was not clear. Do you get what I'm saying?
Yes, sir, I am getting it.
The point of cold ischemia is ischemia. So you're not creating any ischemia to the residual kidney.
Sir,
You're just ligating the segmental vessels, right?
Yes, sir, we are just ligating the segmental vessels, but we did cold ischemia for reducing the metabolism of the kidney. So we can prevent cellular edema and perfusion.
Okay.
Thank you. Dr. Biju Nair next.
Good afternoon. The abstract for presentation today is tumors with a vascular extension, experiences and challenges in the management in our institute. Now to introduce vascular extension of tumor poses challenges in the management. Most common is in the Wilms tumor with IVC extension of 4 to 8% of the cases and right atrium extension of 0.7 to 1% of the cases. Rarely occurs in other tumors like adrenal tumors, clear cell sarcoma, kidney, hepatoblastoma, hepatocellular carcinoma, etc. Commonly occurs on the right side. The usual presentation will be asymptomatic. The neoadjuvant chemotherapy causes tumor regression in almost 50% of the cases. And upfront surgery is required in unstable patients where there is a chance of thrombus dislodgement. Now, for the aim of the study is to share our experience and challenges in the managing tumors with a vascular and atrial thrombus. We had got 4 cases, 3 of which were Wilms tumor and one was germ cell tumor. In the Wilms tumor, we had 3 scenarios. One was intrahepatic thrombus, second was retrohepatic, and third was thrombus extending up to the right atrium. And in germ cell tumor, it was suprahepatic with involvement of hepatic veins. Now, the methods were, materials and methods were retrospective review of electronic medical records of all pediatric tumors having vascular and or atrial extension in the period between 2021 to 2024 in a single unit of our department. The data was collected regarding patients' demographic, site and site of tumor, preoperative presentation, histopathology, chemotherapy, and follow-up. Now, all these 4 cases were put together and compared. First one, germ cell tumor was 3-year-old male child of 10 kilogram, presented with abdominal mass and abdominal discomfort of 3 months duration. The only positive finding in that was the tumor marker, which was elevated alpha-fetoprotein 64,281. And in that case, all these cases were given neoadjuvant chemotherapy. And the response is based on the type. And GCT, the response was extremely very good. And workup showed no metastasis. Second case of the Wilms tumor, 1-year-old child, male child, 9 kilogram. Again, abdominal mass of 6 months duration, had vomiting in 15 months, low grade fever 15 days. There was no comment on tumor markers. Response to chemotherapy was good, very good, and there was no metastasis. And the second case, second Wilms tumor was a 3-year-old female child with abdominal mass greater 7 days and fever of 7 days. Again, the response to chemo was good and was no mets. And third was 3.5-year-old male child, 12 kilogram, present with hematuria of one year on and off, and abdominal mass of 1 month. Again, the chemotherapy was good, and there was no metastasis. Now, what is the type of surgery done in these cases where germ cell tumor, retroperitoneal mass with the involvement of the right adrenal liver with a tumor thrombus in right hepatic and inferior vena cava, reaching up to aortocaval junction. And after chemotherapy, there was 50% reduction in size of tumor. IVC thrombus was reduced just below the hepatic vein ostia. Right hepatic vein has no thrombus, and alpha-fetoprotein they reduced to 75 nanogram per ml. So that was the response with the chemo. And in Wilms tumor, first case, there was a reduction in size of tumor and extent of the tumor thrombus was also there. This was also based on the stations of the thrombus 1, 2, 3, 4 that renal, intrahepatic, suprahepatic, and retrohepatic. And third case of Wilms tumor had a reduction in tumor size and extenothrombus to retrohepatic IVC. Now, this is the picture of images of the CT images of the cases. So the fourth case, so the first shown is the fourth case, which showed a thrombus in the right atrium. This is a case description. The first case surgery performed was mass excess the total with tumor
Vijay, time is
part of
over.
adherent to the liver, right adrenal gland with the cavectomy of 5 centimeter thrombus. Second case, cavectomy was done.
Vijay, you need to stop. Your time is over.
Yes.
Your time is over, please.
Just wanted to ask one thing. You categorized your, results into good, very good, and extremely good.
Yeah.
If I can get you right, was it based on the reduction of the intravascular component of the tumor, or it included
was,
the whole tumor as well as the alpha fetoprotein?
No, it was both, sir. It was reduction in the size of the tumor as well as the reduction in the alpha beta protein level. Response evaluation criteria solid tumor based on that.
Thank you.
Thank you.
Next, Dr. Nidhi S. Patil.
Respected chairpersons, dignitaries, and dear colleagues, I'll be presenting greetings from AIMS Delhi. I'll be presenting a study on juvenile granulosa cell tumor of the ovary in children. It's a very rare malignant pure sex cord tumor, and with an estimated incidence of pediatric ovarian tumors of about 2.6 per 1 lakh girls, JGCT accounts for only 5 to 8% of the ovarian malignancies and 5% of granulosa cell tumor. Approximately 90% of them are prepubertal tumors, and they are hormonally active. They typically secrete estrogen, and granulosa cells also secrete emethin, which can be useful as a tumor marker. Majority of them have manifestations of precocious pseudopuberty, and most of them present as stage 1 tumors, with them generally having favorable outcomes and respond to surgery alone. The general agreement is that patients with metastatic tumors should receive treatment, but there are no proper guidelines stating who should receive chemotherapy. The aim of the study was to assess the presentation, diagnosis, treatment, and the outcome of juvenile granulosa cell tumor of the ovary in children. A retrospective study, including children less than 12 years of age, registered at Pediatric Surgery Tumor Clinic, IRCH, from 2005 to 2023 was done. POG staging was done for all these patients. Total of 11 patients, all of them female were included, with age at presentation ranging from 12 to 132 months, with median age of 35 months. 10 of 11 patients had features of precocious puberty, and with vaginal bleeding and breast enlargement, the most common, seen in 8 patients and 6 patients each. Other presenting features were premature appearance of pubic hair, pain abdomen, abdominal mass, abdominal distension. The basis of diagnosis was clinical features of precocious puberty, ovarian mass on imaging, raised serum estradiol levels, and histological confirmation after resection was definitive diagnosis. All of them underwent surgery. 5 of them underwent oophorectomy, and 6 of them underwent salpingo-oophorectomy on the affected side. One of the patients had an incidental finding of paraoophorean cyst on the contralateral side and underwent excision in the same setting. One each patient underwent omental biopsy and omentectomy. Around 82% of them belong to stage 1 and stage 2, and only one of them belonged to stage 3 and stage 4. One patient received chemotherapy. All of them were followed up from a range of 24 to 132 months, with median follow-up of 43 months, with clinical examination, serum bilirubin levels, and ultrasonography. Symptoms of isosexual precocious puberty regressed in all of the 10 patients. We had 2 recurrences, one 74 months after primary surgery on the contralateral side, and she underwent oophorectomy. But the recurrence histopathological examination showed mucinous cystadenoma. Another had a recurrence 6 months after primary surgery and was found to have peritoneal and liver metastasis. This patient was started on 4 cycles of TB chemotherapy. She received it, and then the patient was planned for surgery. But in view of extensive disease, she underwent only tumor biopsy and omentectomy. Then she received 3 cycles of paclitaxel or carboplatin, and metonomic therapy with tamoxifen and immunotherapy with imatinib was given. To conclude, JGCT of the ovary presents with varied features of isosexual precocious puberty, and stage 1 JGCT have very good prognosis with complete excision, and they have complete regression of features of isosexual precocious puberty. and they do not have recurrence without any adjuvant chemotherapy. So surveillance can be a good option in these. Thank you.
Any questions from audience? Thank you, doctor.
Yeah.
Last presenter, Dr. Tarun Kumar.
Greetings from SGPG Lucknow. I'm Dr. Tarun, presenting a diagnostic and surgical challenges in rhabdomyosarcoma of biliary in a 2-year-old. So biliary RMS is the most common malignant cause of obstructive jaundice in pediatric patient, and more than 90% of cases present within 5 years of age, and it closely mimics the colorectal malformation or inherited cyst disease. The diagnostic roadmap consists of radiological investigations to know the complex cystic or solid extent of the cyst, and to know the nodal and extent of the disease and nodal involvement. And therapeutic modalities can be used to drain and stent the obstructive system. But definitive diagnosis is based on the histopathology and IHC, which will give us histology, and we can prognosticate the child. And role of PET scan is to evaluate the metastasis. So principle of surgical management pertains to the upfront surgery, delayed surgery, or re-resection of residual or recurrent tumors. And conservative surgery, we can go from conservative surgery to the extended surgery, and also liver transplantation. So our index case is a 2-year-old male child with complaints of obstructive jaundice and cholangitis. So initial ultrasound suggestive of cystic lesion in the porta. But due to intractable cholangitis, a PTVD was done. You can see the cholangiogram with large filling defect and multi heterogeneous mass in the CBD with gallbladder. So a CECT was warranted, and working diagnosis of complex colorectal cyst was made. But we gone ahead with the MRCP, which gave us the idea after reviewing the literature and discussion with the radiologist of rhabdomyosarcoma of the biliary tree. An upper GA was also done, which showed a bulge at the ampulla, and biopsy was taken with mixed cellular infiltrates, and ERCP could not be done. So we did a biopsy through the PTBD tract. We upsized the PTBD tract to 12 French, and then with the 4 French of cholangioscope, we did the biopsy from inside only. And that gave us the definitive diagnosis of rhabdomyosarcoma. And the child was started on VAC therapy. 6 cycles were given, and due to the reduction in size and significant clearance of jaundice, the patient was planned for surgical excision. So this is the incision, Makuchi incision. The inspection of mass was done, and its relation with the adjacent structures were taken. And the dissection was started. The duodenum was removed anteriorly from the mass. And as you can see, D1, D2 region, and the CBD mass in relation to pancreas. The CBD connection distally was removed with the cuff of ampulla, and distal dissection has been done. And the proximally, we gone till the hilum by removing some part of the neck of the pancreas, which were distally adhered to the mass. And it is the posterior dissection is completed till the hilum, and all the structures were saved. And anterior crossing right hepatic artery was looped. CHD CBD junction was divided in its upper limit by taking the safe margins. And you can see the wateroid mass protruding from the mass, and a single ostia with clear margins for HJ was taken. And ruling was created. Jejnostomy was done in 2 layers. Beggar's modified pancreatic jejnostomy was done with the one side of jejunum was anastomosis with the head, and the neck of the pancreas was dunked into the jejunum, and distally HJ was done in the same route. And this is the complete anastomosis, proximally PJ and distally HJ with rulim and JJ. So histopathological report was that the margins were clear of tumors, and we have taken liver biopsy, which shown the distorted architecture and intracannular cholestasis, and lymph node, omental, and other tissues were free of tumor. The postoperative course of the child was STOMI. He had subacute obstruction of subacute gastric outlet obstruction with delayed contrast hold up in the stomach. So we did a gastrojejnostomy in the rule limb distal to the HJ. And but during postoperative 7, there was fluids coming out of the main wound. So child with a guided prognosis, the parents decided to go for LAMA. So it's the largest meta-analysis with 65 studies, which concluded that the absence of surgical resection is an independent risk factor for death, along with the alveolar histology. So in concluding, biliary RMS closely mimic a complex polyducal cyst, and high-resolution imaging and tissue diagnosis must for prompt diagnosis and treatment. Thank you.
First of all, it's clearly index case where you had very good pictures. Regarding the stools from the wound, what were the cause you think?
Sir, the child post chemotherapy had immunosuppression also. He was very weak. We think that we suspected that the FJ site has been perforated due to his nutritional deficiency. So his malnutrition was the cause, we think. And
the tumor was in the intrapancreatic part of the CBD, if I am not wrong.
Sir, whole of the CBD from CHD CBD junction till the ampullary part, and the part of the neck of the pancreas was densely adhered. We have to remove that along with the mass.
You did a Whipple's sort of a thing?
No, sir. No, sir. We didn't did a Whipple. We preserved the duodenum. We didn't did a Whipple. We just removed the part of pancreas, the neck, the short strip of neck, and we dunked the neck into the jejunum, and the head also was anastomosis. It is a beggar's modification of pancreatic jejunostomy we done, sir.
Any question from audience? Dr. Ankur wants to. Thank you.
Thank you.
For information, we are going to distribute prize as many people are going. So all residents need to be here. We are going to distribute the prize and announce the name, poster presentation, both podium, just after 5 minutes. Okay. If someone, your friend is outside, please call her or him.
I'm requesting Dr. Anjum, ma'am. Requesting Dr. Anju Verma, madam, to present a token of our gratitude to Deepak Kanpal sir, Vijay Kunal sir, and Nitin Pant sir.
You are on right time. We are going to distribute the prize.
I'll now invite Dr. Basant Kumar sir to take over the dais for the prize distribution.
पेपर नहीं है, मैं तो मैं लेकिन मेरा नाम कहीं से अरे कहीं मेरे पास
हो जाएगा। कोई बात नहीं, कोई बात नहीं। Now we are going to open this Pandora box. Okay, so first we will start with one paper will be moved by ma'am. I thought the baby no. From college, pharmaceuticals. This was Dr. Rohit Kapoor. Now my teacher, Bango Pandya sir. सर आप नीचे से मेरी बात करते From Kabir sir, my other teacher. He, sir, कभी ना मिले। सर कभी ना मिले। सर पहले ही रिपीट कर रहा है। आपके रेज़्यूमे की जॉब बता You all got your prize because of your hard work.
Yeah, thank you, sir. So now I am announcing the prize. Susmita ma'am, please come on dash. This poster session. Dr. Kaushal Kulkarni from AIMS Delhi, first prize. And believe me, it is. अच्छा सर विल टेक। तो ये बंद कर नहीं रहने दीजिए मैम, फोटो आएगी। अच्छा तो फिर एक मिनट इसको बंद करके ये इधर स्टार्ट करते हैं। Yes, Kaushal Kulkarni. And result is very honest. Believe me. None was from SBPGI. Thank you, sir. Second is Sanchita Singhal, AIMS Jodhpur. Singla, AIMS Jodhpur. Dr. Sanchita Singla. Congratulations. Okay, Sanchita party. Before party, you can't go. Come Lucknow. Third prize is Dr. Nishant Agrawal from SGPGI Lucknow. Rohit, go with them. Come, you stand with me. And you can also go. आप वहीं पे किसको करवा दें, किसको बताइए, संदेश को करवा दें। सारे लोग आ जाए, दोनों लोग आ जाए, बाकी पोडियम।
For paper session 1, free paper session, the first prize goes to Dr. Tarun Kumar from SGPGI Lucknow. The second prize goes to Dr. Pooja Prajapati from SGPGI Lucknow. The third prize goes to Dr. Ankur Bhardwaj from CNBC Delhi. For free paper session 2, the first prize goes to Dr. Nishant Agarwal from SGPGI Lucknow. The second prize goes to Dr. Preeti Kumari from KGMU Lucknow. The third prize goes to Dr. Sugandha Agarwal from AIIMS New Delhi. Congratulations to all the winners.
And you are going or we can proceed for that, right? No? Okay. So just please come for lunch and it's 20 minutes only, 15-20 minutes. We will get this for last session. Okay. Yeah. Yeah.
So before you all go, I just will take 2 minutes of your time. I want to sincerely and heartfelt thanks to the local organizing team. Dr. Basant has been the secretary of APSO as well as the organizing committee chairman. So he was playing a dual role and both the roles he has maintained and he has fulfilled extremely well. I'm just so proud of the entire team, of my team APSO, of the entire the LGPGI team and everybody who has contributed. Sincere thanks and I'm really very grateful to you, really. Everything was excellent. Your hospitality was excellent, scientific sessions were excellent. I have contributed to some extent, yes, but you all have carried it out. That is what is more. So always it is like implementation. I keep saying implementation. You all have implemented everything extremely well. Thank you again, Dr. Ankur. Thanks to you as well. You, you have also been a part of the team and everybody here. So that is my first statement that I wanted to make since the time I've landed over here. Apart from that, thanks to all the delegates and all the students who have wholeheartedly participated in the discussions as well as in the scientific sessions at all levels, including the free papers, the posters. Absolutely fabulous. I really encourage you to keep raising the bar. Thank you very much again. And my international friends and guests for this event. I am just so proud, feel humbled as well as proud that you all have accepted our invitation. And in spite of all difficulties and challenges and so many trips that you'll be making in this month and the next month, still you'll have managed to be here with us and interact with us and also give us a global perspective of the entire situation of pediatric surgical oncology. I'm really thankful to you as well. So I will be seeing you again probably in the next APSOCON or sometimes in between any online sessions that we will be organizing. Please participate, please talk, please discuss, because that is the first step to the progress. Thank you again.
Thank you, ma'am. Before we break for lunch, if the residents are available, we'll conduct the quiz after the lunch. Quiz competition. If residents are available and interested. Yes, and there is also prize distribution after the quiz. I mean, for the quiz winners. This all has been done for the quiz.
Sir, I will message you what are our plans. Okay, okay. I will yes, yes. Yeah, so you get my name and number from okay. So we'll see. Yeah. You sent those from something. Yeah, okay. So that we can. Next time, yes. Okay, thank you. Thank you. Yeah. Yeah. Okay, thank you.
into photo marketing.
एक यहाँ ले लीजिए। हो गया।
सबको बुला के मैंने सबको बुलाइए।
हाँ तो बाहर बाहर रख देंगे।